he's struggling through it, he'll be able to figure it out. Get through the mystery that is kidney.
Testing.
All right, but today we're going to do some
Testicle.
skin. So we're talking about tumors. We did some of the most important ones. We did melanoma, 5 stars. We talked about squamous cell and basal cell. These are very high yield topics. You're going to see these very common tumors to see. Now, the next tumor we're going to talk about is let's see what's coming up next. Oh yes, mycosis fungoides. Those are like mucosa, like mucosa. This is a T cell tumor of your skin. And we talked about this in the white blood cell pathology chapter. This is a disease that Mr. T got. I'll pity the fool who don't know mycosis fungoides. It kind of looks like a fungus because I get this ulcerating rash, and you put steroids on, it gets worse. I'll pity the fool who gives you steroids. Now, it's a cutaneous T-cell lymphoma. Remember, it's got tropism for the skin. It has antigens that make it look for the skin. It homes in on it. And these are CD4 positive helper cells. They're T cells. I always remember the A team, there was 4 members, and they were always helping everybody. That's how I remember Mr. T's disease. Now, usually you're over age 40, and Mr. T was at the time of diagnosis. And what it looks like, it's usually on the trunk, but for him it was behind the ear, so it could be anywhere. But it's scaly red-brown patches. So these red-brown patches that start to ulcerate. See them? They're ulcerating here? It's getting much worse. So these red-brown patches, or sometimes plaques, and then they can become big like nodules over time. So they can progress to nodules. And they can ulcerate, like in this case, this is all ulcerated. This is just nasty looking skin. It's not the kind of stuff you want, right? Now, many cases are just going to stay in the skin. They have tropism for the skin. They stay there. But eventually, they will spread into the blood. When they do, you'll see Sézary cells in the blood. We call this Sézary syndrome. Now, the prognosis for T-cell tumors is usually terrible. So when it spreads, it is a terrible tumor. But if you catch it before it spreads, this is usually locally treatable. So Mr. T got cured because you could put chemo right on it, you could radiate it, you can even try resecting that area of skin, because it stays local for a long period. So even though this is a T-cell tumor, if you catch it early, potentially curable. And for Mr. T, we cured him. Now, you always have to watch, though, because in the future it could recur. But check the blood. The blood's negative, you're good. If it's Sézary's, you're in trouble. Now, if you remember, one of the key features here is we're going to see a band-like infiltrate of T cells coming in. But they have tropism for epidermis. So I think you can see this dark purple dot, this dark purple dot, this dark purple dot. These are some lymphocytes that are actually going up into the epidermis. And they're going to form what they used to call microabscesses. They thought they were abscesses, but they're just funny-looking bumpy T cells. And they call them Porträt's microabscesses. So here it is, a band-shaped infiltrate. So like a band in the dermis, a band-shaped infiltrate of these atypical T cells. But the key is they're going up into the epidermis. You'll see these clusters here. Look at these clusters. And then, of course, if we blow it up, here's what you'll see. These bumpy looking, they're kind of not round like they should. They're kind of irregular, bumpy looking. Look at this one. That one almost looks like a neutrophil. It's got a little projection there. So before they had immunohistochemistry to know these were lymphocytes with CD numbers, they thought they were abscesses. So they call them Porträt's microabscess. It's a misnomer. It's not an abscess, but that's what they call it. Porträt's microabscess, very important. It's like a hallmark feature. If you hear clusters of lymphocytes in the epidermis, in the dermis, that could just be dermatitis. But you see it in the epidermis, clusters like that, that's going to be mycosis fungoides. And again, these cells tend to have a bumpy or cerebriform, hyperconvoluted nucleus. So instead of being round like a lymphocyte should, it's kind of a bumpy, 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 bumpy. And so people say it looks now like gyri of the brain. So they call it a cerebriform. It looks like the brain. So we take a look, here it is. Bumpy, bumpy, bumpy. It's like hyperlobulated. They say it looks like the brain. Now, when you see it in the blood, this is now called the Sézary cell, when you see these funny-looking bumpy T cells in the blood. And again, that's a poor prognosis when it goes to the blood, Sézary's. All right, so we've done this one twice now, so if you ever see it on an exam, you should definitely nail it. And Mr. T will be happy. You won't pity the fool. Yeah, my prognosis for USMLE, pain. Taking the USMLE is painful, but you're going to make it through like everyone else does. All right, now here's a very interesting disease, mastocytosis. So mast cells, those are basophils, right? They're basophils in the blood, then they go into your tissue, you call them a mast cell. So this is a spectrum of disorders where there's increased numbers of mast cells, either in the skin or the skin and other organs as well. A classic example would be a disease called urticaria pigmentosa. This accounts for 50% of all cases of mastocytosis. Remember, mastocytosis, big term for increased number of mast cells. So a disease of it is called urticaria pigmentosa. Now it could be local or it could be systemic, it could be all over the place. Now clinically, what are you going to find? You're going to see signs and symptoms of the release of mast cell products. Mast cells release histamine, they release serotonin, they release some heparin. So that's what we're going to see. We're going to see some flushing, we'll see some itching. Histamine makes you very itchy. Flushing, itching, maybe some mucosa bleeding, potentially. But it's mostly itchy, flushing, stuff that histamine causes. Now, a couple of important clues. Number one, Darier's sign. Darier's sign. This means if I rub this itchy skin, you will suddenly get edema and erythema. So basically, remember the term wheal? Wheal is a term for dermal edema. So you'll get this wheal and flare reaction. So you just rub the skin and boom, there you get a big wheal and flare. Now another interesting finding, dermatographism. Now, derm is skin, graph is writing. So if I literally write on your skin, so I take a pencil, I take the eraser and I write my name, it will literally become edematous and red in that area and you'll see the writing. So you can actually write on somebody's skin. It's like, you are I. Or put a heart and put your names. Crazy. So stroking the skin with some sort of pointed instrument will produce dermal edema. And it looks a lot like hives. It's like wheals, looks like swelling. So again, we have two things. Rubbing the skin, Darier's sign. Writing on the skin, they call it dermatographism. It's the same thing. There's too many mast cells there. So if you rub them, they're going to release their histamine and it will have local edema in that area. Now, what's causing these mast cells to proliferate like this? Well, we often find activating point mutations in CK. Okay? Now, this is what's called a solitary mastoma, where you just have one large collection of a bunch of mast cells in the skin. Notice it's red, it's swollen, it's just local. So that would be a local form. But most cases are going to be more systemic. Now, if we did biopsy this, here's what we'll see. Nice epidermal layer. In the dermis, we see all these mast cells. Oh, you prove it? Okay, we can do a Giemsa stain. When we do a Giemsa stain, you see all this purple, bluish stuff here. Purple, blue, it's kind of like different colors. They call this metachromatic granules. Those are the granules that have all the histamine and the heparin and the serotonin and all the other features that these mast cells are supposed to have. Again, these are all the contents. That's what all this purple, blue stuff is. All right, let's go on to another tumor that's very rare, but you have to have heard of it. Merkel cell carcinoma. This is a tumor of the Merkel cells of the skin. Now, Merkel cells are normally present in your skin. They're neuroendocrine cells, and they're located in the basal layer, the stratum basalis, the basal layer. They're associated with nerve endings, so they may be important for touch sensation as well. So they may play a sensory role, they have a neuroendocrine role. All I know is when they turn malignant, they're going to be very similar to small cell of the lung. Because small cell of the lung came from Kolchitsky cells, neuroendocrine cells of the lung. So it's very, very similar. It's almost just as aggressive, by the way. So Merkel cell carcinoma usually arises in the head and neck area of elderly Caucasians. That's usually where we see it, head and neck of elderly Caucasians. And we think it's associated or caused probably by the Merkel cell polyomavirus. Now, I love that. Name the virus, what it's associated with. I love it. The Merkel cell polyomavirus. I wonder what that's associated with. Merkel cell carcinoma? Oh man, why can't they name all of medicine like that? It would be so easy then. So that's kind of hard for them to ask a question like that, right? Which of the following tumors is associated with Merkel cell carcinoma? Yeah, you wish. Too easy, right? then anyone could do medicine. We wouldn't get paid the big bucks. True. All right, now, when we biopsy it, they're going to come in with a bump or a mass, and we'll biopsy it. We'll see solidness of very undifferentiated cells, so they're just mostly nucleus, not much cytoplasm, and it looks a lot like small cell of the lung. So you got these clusters of small round blue cells, clusters. In fact, whenever I get this biopsy, I look at the epidermis, looks okay, looks a little like a little hyperkeratotic, a little parakeratotic too. It's a little irritated from this mass underneath pushing up on it. But basically, it looks like lung cancer in the skin. So truthfully, when I make this biopsy and I see this, I have to ask them to check the lung. Before I can call it a Merkel cell, I got to make sure that it's not a lung cancer. So I always ask them, hey, because it's got the same neuroendocrine markers as lung cancer. I can't really tell it apart with staining. So we have to make sure that it really is, there's no lung cancer present. If there's lung cancer, well, then it's metastatic. If the lungs are clear, then you can call it a Merkel cell. Notice, same markers, chromogranin, synaptophysin, these are classic neuroendocrine markers. They were also positive for pheochromocytomas, small cell of the lung. Anytime you have a neuroendocrine tumor, these are good markers for it. Now, just like lung cancer, very aggressive, high mortality. Yeah, I've had a couple of these cases, and pretty much, I don't think any of them survived more than 5 years. I'm trying to think. Not a good tumor to see. I never like it when I have the diagnosis. And again, usually when I see it, I say, is there lung cancer? And they say, yeah. So I say, okay, it's metastatic lung cancer. But if there's no lung cancer, then they call it a Merkel cell. All right, now what about some tumors of the dermal areas? Because Merkel was in the epidermis, the basal cell, that was the basal cell, the hair follicles, squamous cells, obviously the keratinocytes, the squamous cells. But what about dermal? Well, in the dermis are fibroblasts, right? So we can have malignant tumors of the connective tissue, the fibroblasts. Now the first one is called dermatofibroma. Cool, dermato, skin, fibroma, fibrous tissue, right? Tumor of the fibroblasts. And it's benign, OMA is benign. Another name for this was benign fibrous histiocytoma, because some of the fibroblasts can get kind of plump and kind of look like histiocytes. So sometimes they call it fibrous histiocytoma, just an older name for it. Now, this is usually in the mid-dermis. It's composed of fibroblasts and some plumper fibroblasts, which are probably histiocytes. So, fibrohistiocytoma. Cool. Now, overlying the epidermis is going to get thicker. It's going to get thicker. So, as this pushes up on it, the epidermis will literally thicken. But here's the key. The tumor is negative for CD34. Now, why do I care? Because this is benign. Malignant tumors of fibroblasts are going to be CD34 positive. So this is the critical lesion, the critical thing to see. So OMA is a benign tumor of the fibroblasts. Fibrosarcoma, this is the malignant version. And you don't want to miss a malignant tumor. Okay? So again, dermatofibromas are benign. They're in the mid-dermis. There's a little hyperplasia overlying the tumor, but the tumor is negative. The tumor cells are negative for CD34. Now, who gets it? It's usually adults, usually young to middle age. Now, let's compare it to its malignant cousin, dermatofibrosarcoma protuberans. Do you think this is going to be a mass that's raised, protruding into the above the skin? You bet. Now, this is a well-differentiated fibrosarcoma, so that's good news. Poorly differentiated things, the less differentiated, the worse the grade is. Grade is about differentiation. Does it look like normal, or does it look ugly? So this is a well-differentiated form of fibrosarcoma, CD34 positive, very important. Now, it's locally aggressive, and it can recur. If you don't get it all out, you cut through it, it will come back. But the good news is it rarely, if ever, metastasizes. So it's a malignant tumor. It can be very aggressive locally, but it doesn't usually spread. Thank goodness. Now, what does it look like? It's kind of cool. Under the microscope, the fibroblasts are kind of arranged in this storyoform pattern. Well, if you ever gone to like a fair and you got a pinwheel, you know the thing where you blow it and the wheels, it spins around, right? Well, pinwheel, right? It's got this stick, And then it's got this, and then it's got another one going like this, and then another one going like this, another one. Oh boy, this is the worst looking pinwheel ever. Okay, there we go, that's a little better. It's got this wheel, this pinwheel. Well, that's what happens. These cells are kind of elongated going in this direction, right? This direction. And then over here, they're going in this direction. In this area, they may be going a little more in this direction. And in this area, they're definitely going like this direction. So it's kind of like radiating out from that central area. And again, this may not be the best picture of it, but it's going to kind of look like it's radiating out, like the wheels of the pinwheel. And the pin should be in the middle holding those little fans, those little things together. So that's kind of a cool thing to talk about. It's got this storiform or pinwheel-like pattern. Now, since it is invasive, it's a malignant tumor, it's going to invade the fat, subcutaneous fat. And when it does, it kind of infiltrates between the fat cells, so it starts to look like Swiss cheese. So here we got nothing but tumor, and then notice the fat is kind of trapped inside it, and then the tumor goes in between it. See the tumor going in between it, this purplish stuff is in between. So it kind of makes it look like Swiss cheese. You go like, here's a hole, there's a hole, here's another hole, here's a bunch of holes together. That's more, fat should be a bunch of fat cells, not much in between. So this is kind of infiltrating between it, making it look like Swiss cheese. Another cool pattern. So we got pinwheels at the fair, and then we get a Swiss cheese sandwich. Swiss cheese and pinwheels. All right, CD34 too. Now, what's causing it? It's usually overexpression of platelet-derived growth factor. That's what's stimulating these fibroblasts to grow. And of course, here's the picture. Why they call it protuberans? Here's your epidermis coming along, and then boom, boom, big old bump protuberating from the surface. Now, what do you think the color of a fibrosarcoma is going to be? You think it's going to be white? Yeah, fibrosis is white. So very white, firm tumor. And notice this one going down into the yellow fat. It's infiltrating into the fat. So it looks pretty well circumscribed. I think that this person definitely is cured. They got a good margin on this bad boy. See, by the way, see the black on the edge here? Whenever they give me a specimen, I put black ink at the edges, because then under the microscope, that will tell me what the edge is. When I see the black ink, I know that's the edge of the specimen. So we put black ink at the edges here to see, did they cut through it or did they get around it. In this case, even on gross, it looks like they got around it. We'll check with the microscope, make sure that the tumor is away from the edge. Okay, if the tumor's at the edge, they cut through it. If the tumor's away from the edge, like in this case, you're most likely going to be cured. That's good. That's dermatofibrosarcoma. Again, CD34. If I was going to ask something, I would give you the CD34. I'd say firm mass in the skin. It's got spindle-shaped, elongated cells and a storiform pattern with CD34. And you'd have to say dermatofibrosarcoma, malignant tumor. All right, now this one always freaks me out. Take a look at this. It's like, dude, are you a snake? Are you like Guns N' Roses lead man? Do you remember Guns N' Roses? He would like snake as he would sing songs. Welcome to the jungle. Did you become a snake suddenly? I mean, look at this. You're like scaly, dude. You're like a crocodile or something, like a snake. You're like scales. So this is called ichthyosis, I can never pronounce it. Ichthyosis. Ugh. Now, in Greek, ichthy means fishy. Well, it kind of looks like scales of a fish. I like snakes, but they think it looks like scales of a fish. So ichthyosis. Now, this is a group of disorders where there's a problem with the epidermal maturation. So you get lots of keratin buildup, hyperkeratosis. That's what these flaking scales are. It's too much keratin. You're just not releasing it. It's just building up, and you're not flaking it off. So you get these big flakes now of hyperkeratosis. Looks like fish-like scales. Now, there's a bunch of forms. We got the hereditary forms. We've got acquired forms. Obviously, hereditary forms are often diagnosed early, especially the recessive ones. They're usually diagnosed at birth. So they're picked up pretty early when the kid looks like all flaky and stuff. And then there's acquired ones, and I think that's probably more interesting, the acquired ones. So you can acquire this as a paraneoplastic syndrome. So again, suddenly somebody becomes a snake, you might want to start looking for an internal malignancy. So now we have seborrheic keratosis, suddenly you develop 100 of them all of a sudden. That's called the sign of lesser tree-lac. We have the thick, dark skin in the axilla, the neck, and the groin. That's called acanthosis nigricans. So these are all potential paraneoplastic syndromes. They can all be associated with tumors, which is always interesting. Now, why do they look so scaly? It's a problem with desquamation. In other words, the squamous cells die, but they don't get shed. They just kind of build up and they become scales. Okay, so under the microscope, we're going to see hyperkeratosis. So basal layer, spinosum, the spinous layer, the granular layers right here, this blue layer here is the granular layer with little blue dots. And then this pink layer here without nuclei, this is going to be the keratin layer. But look at how darn thick this thing is. This is like a giant callus almost. I mean, that's really thick. And that's why it looks so white in these areas. It's just very thick skin that's not shedding off. We're supposed to shed our skin. That little keratin layer, it should keep falling off. But this, the keratin just builds up, gets really thick. Again, think of paraneoplastic. All right, now we're going to switch gears. Now we're going to talk about inflammatory conditions of the skin. We're going to have acute ones, and then we're going to have chronic diseases, chronic inflammatory dermatitis. So let's start with the acute ones first. Acute inflammation of your skin. And in this category, we have three things. We have urticaria, which is hives. We have acute eczematous dermatitis, which is just simply called eczema. And then we have this one. This is the most testable. Erythema multiforme. Red, multiple forms. Multiple forms. You'll have target lesions. You'll have patches, plaques, nodules. You have different forms of red lesions. And that's going to be one of the most tested. Now, what do these three lesions have in common, aside from all being acute and all inflammatory? Well, acute means they come on quickly. They come on quickly and they only last a short period. So they last a few days, a few weeks, and then they go away. They don't last forever. So you get an episode where one day you get all red, the next day it's gone. Or for a few days you turn red, a week later it's gone. Now, under the microscope, what are we going to see here? Well, it's inflammatory. So we're going to see inflammatory exudates of lymphocytes and macrophages. Lymphocytes, that's what they have in common, lymphocytes and macrophages. In addition, there's going to be edema. It's acute, it's inflammatory. You're going to see inflammation and edema. And then finally, you may have epidermal, dermal, or vascular injury. So notice acute injury to the epidermis, the dermis, or to the blood vessels. Okay, so we'll see acute inflammation damaging these areas. Question, when you damage an epidermis and the cell dies, the lymphocyte told it to die, we often call that apoptosis. So you'll see apoptosis of the keratinocytes sometimes. All right, now let's go through these one at a time. Here's the first one, urticaria. Lay people call it hives. Hives. You've heard of hives? All right, now this is an allergic reaction, type 1 hypersensitivity. Type 1 oh, it's right there, type 1 hypersensitivity. Now this is mediated by IgE. This is going to be mast cell degranulation, right? So when I get exposed to certain allergens like pollens, or I eat shellfish that I'm allergic to, or peanuts, whatever I'm allergic to, or certain drugs, you can get hypersensitive reactions to drugs. Insects, get bit by an insect, you can get hives as well. So this is some allergen that you're exposed to, and then your mast cells just go crazy. They release everything. And you're going to see dermal microvascular hyperpermeability, because histamine causes blood vessels to dilate and become leaky. So right away, I think you can see in this picture, do you see these dilated little vessels here? Do you see how dilated they are? Yeah, they're really dilated. Now, if you look at the dermis, do you see how pale it is? See, it's really pale. So it should be much more pink. It's really pale. You can see like the little keratin bundles. Look at these little fibers here, little keratin. They're kind of all separated by all this edema. So this is dermal edema. This is what a wheal looks like under the microscope. What does it look like grossly? A swollen red area. Itchy, red, and swollen. from the histamine. Itchy, red, and swollen. This is called the wheal. Under the microscope, it looks like dermal edema. So dilated vessels and really pale collagen because the water is in there. Makes it like so pushes all the keratin, all the connective tissue apart, makes it look very pale. All right, so remember the term wheals. Wheals and flares, itchy red plaques. Under the microscope, as I mentioned, you'll see the subtle infiltrate of lymphocytes. So if we take a look next to these vessels, do you see there's 1 or 2 nuclei here? 1 or 2 purple dots? Not many. Here's another purple dot here, a little lymphocyte coming in here. Here's 1 or 2. Man, this is a really subtle inflammation. There's only a few lymphocytes in there. If you missed it the first time, I don't blame you because there aren't too many to see. Now again, the collagen bundles, the fibrous collagen bundles, they're being pushed apart by the dermal edema, kind of splayed apart. So here's a nice collagen bundle, nice pink bundle, and then in between is water. There's another collagen bundle. So it's just being pushed apart by water. So that's hives. Allergic reaction. Stop the pollen exposure. Stop the drugs. Stop whatever's triggering it, and it will go away. All right, now let's compare this to eczema. Eczema. Now in Greek, eczema means the skin is boiling over. You know when things boil, bubbles come up, right? Take a look here. See, it's red. It's inflamed. It's red. But do you see the way it looks like it's almost about to make a blister there? It's almost blistering there. It's going to be weepy. It's swollen, red, weepy. Yeah, it's starting to boil over. Your skin looks like it's bubbling almost. It's about to boil. So that's why they call it eczema, because it looks like your skin is inflamed and about to boil over. So again, we're going to see itchy red papules. Papules are elevated, right? Often overlying vesicles. So it literally is bubbling. You get these fluid-filled little spaces here. And it oozes. It releases the fluid, oozes, and then becomes crusted. So crusting, oozing, red, inflammatory lesion. That's eczema. Your skin is boiling. Now, over time, this can produce a plaque. So if it becomes more chronic, it starts becoming plaque-like. Now, it's most common on the flexor surfaces. Flexor. So you'll see it here, inside your forearm here. You'll see in the neck area. Any of the flexural surfaces, those are the areas we most likely see it. Now, what are we going to see morphologically? Okay, number 1, is there dermal edema here? Do you see the way this is very white here, down in the dermis? Oh yeah, there's dermal edema. Is there a faint infiltrate of little lymphocytes in here? Probably. Little lymphocyte infiltrate. Again, mononuclear cells coming in. But what's unique here is what do you see in the epidermis? Do you see the way there's swelling in here? It looks like there's bubbles of fluid in here. There's white spaces. Yeah. So this is called spongiosis, edema of the epidermis. And again, if this fluid area gets bigger and bigger and bigger, it will now become a vesicle. It'll literally become a vesicle. If it keeps increasing and getting more and more fluid in there, it becomes a fluid-filled space in the epidermis. That is called a vesicle. So your skin literally is boiling over because there's edema in the epidermis. So again, that's the major difference here between urticaria and eczema. Well, the other difference is that was type 1. This is more of a type 4 reaction. It's more of a type 4. It's more lymphocytic. Lymphocytes coming in, causing inflammation, causing things to swell up. There's not much histamine here. It's not much IgE. So this is more of a type 4 reaction. Okay, so spongiosis, that's the term for epidermal edema. Look at this space here. Big old space between the keratin layer and the granular layer. All right, now we got 5 categories of eczema. 5 categories. The first one is called allergic contact dermatitis. So you basically touch something in the environment. So something like poison ivy or poison oak. Yeah, your mother told you avoid them with the 3 leaves, but you didn't know. You went out there, you had to poop, you had to wash yourself, you had to wipe yourself, so you took some leaves and you wiped yourself and oh boy, reds on your butt is boiling over. That is poison ivy in the place you never want to have poison ivy. So if you're going to go camping, bring some real toilet paper, or at least know what leaves you're wiping with, because poison ivy and poison oak, that's one place you don't want it. There's another place you don't want it too, but that's definitely a place you don't want it. Now, what's happening here is there's oils on the surface of these leaves. When it touches your skin, you walk by it, it scrapes you, the oils now get on your skin, and what they do is they modify some of your self-proteins. They modify it. So now your immune system, your lymphocytes come in, and you get inflammation. Just because they modify some of your self-proteins and the lymphocytes notice that, they create inflammation. So again, this is a type 4 reaction. I know, they call it allergic. I know, they call it allergic. You're thinking it's type 1. No, all contact dermatitis is type 4. And that is a major question for exam writers, because students think touching something, oh, you're allergic to it. It must be type 1. Nope, type 4. This is all about T cells. All right, now, and that's the most important category for you to know for exams, contact dermatitis. They not only do it with poison ivy, poison oak, but they can also do it with like a nickel watch or nickel jewelry. Somebody gives you nickel jewelry, then cheap stuff, and your ear swells up, and then you know your boyfriend's trying to kill you, right? He's trying to kill me. What are you doing? It's all red and swollen. What's going on? Oh, it must be the fake stuff. You trying to kill me? Buy me the real stuff, right? All right, now another form is called atopic dermatitis. This usually runs in families. Atopic usually runs in families. So they get this eczema with asthma and allergic rhinitis. So notice, this is a type 4, but it can be associated with type 1 and type 1. So that would be a nice little combo. That's called atopic dermatitis when it's associated with those conditions. We also have drug-related eczema. This is just a hypersensitivity type 4 due to a drug. Type 4 hypersensitivity. What about light? Well, light can also damage the skin, change antigens. Well, if the UV light changes antigens, and some people recognize them as different, they can get inflammation of their skin due to light. Then they have to avoid the sunlight. You gotta stay inside. And then finally, we have primary irritant dermatitis. So you try a new detergent, you try a new perfume, and whatever chemicals are in there irritate your skin, and lymphocytes come in. Now, the good news is, for most of these, if we avoid the contact, it should go away. So complete resolution usually occurs pretty rapidly when you remove the stimulus that was causing it. So let's stop using the poison ivy. Let's get out of the woods. Let's stop the drug. Let's get out of the light. Stop the irritation, whatever it was that was causing it. It usually resolves on its own. Okay, so that's good. Excellent. All right, now, probably the most testable and the most important for you to know as a future doctor house physician is erythema multiforme. And again, I like the name. Erythema means red. Multiforme means multiple different appearances to your red lesions. Now, here's the key. It's usually a self-limited hypersensitivity, again, type 4, in response to either an infection that you recently had or a recent drug exposure. So that's what you need to look for. You gotta look for a history of, doc, I recently had an infection, or doctor, I recently started a new drug. That's what you're looking for. Look for it in the history of the vignette. And that's when you gotta think erythema multiforme. Put you on a new drug, you get these crazy red lesions, start thinking about it, stop the drug. Now this is a cytotoxic CD8 T cell mediated hypersensitivity. So again, this is type 4. Anything with T cells is type 4. Now, what kind of infections are going to trigger it? Well, we've seen it with herpes. We see it with mycoplasma. Those are the two biggies. But I've seen it with lots of other infections too. Coccidioidomycosis can get erythema multiforme. Leprosy has been reported. I've never seen leprosy, but it's been reported. Of course, drugs. Drugs are a big one, especially for exams. Sulfa drugs, penicillin, barbiturates, sometimes cyclids, salicylic acids. They can all do it. Now, rarely malignancies, so this could be like a paraneoplastic syndrome of carcinoma or lymphoma, and collagen vascular diseases. These are the possible associations for erythema multiforme. For your exam, these are the two biggies. Look for recent infection like herpes or mycoplasma, or look for recent drugs. They just started sulfonamides. Okay, that's when you want to think of it, sulfa drugs. All right, now, why do they call it multiforme? Because you can have multiple type lesions. You can get red macules, red papules, you can get plaques, you can get target lesions. Does this not look like a target? See, it's red in the middle, but it cleared on the edges. So it literally looks like a target. And very common to get these targets on the palms and soles. Palms and soles. Not many rashes occur on palms and soles. So this is a pretty important one to remember, palms and soles. All right, now again, when I mean multiform, I mean macules, papules. They can have vesicles, so this can blister and get swollen in the middle. They can get bulli. So it's got multiple forms, macules, papules, plaques, vesicles, bulla. Now, the classic lesion, though, is that targetoid lesion. Looks kind of like a target. I know it doesn't look like the shopping target that we all know and love, but it does look like a bullseye or target. So it's a red macule or papule with a vesicular or eroded center. So this is like going to be like a vesicle. If you actually felt it, it's swollen, elevated, full of fluid. So that's the favorite lesion, these targetoid lesions. Very characteristic, often involves symmetrically the extremities, the palms and soles. Okay? All right, now here's the bad news. There are worse forms. So this is called the mildest form. When you get these red inflamed lesions all over. Oh, and I forgot to mention, what does it look like under the microscope? I forgot. Okay, we're going to see what's called interface dermatitis. What does that mean? It means the infection or the drug probably modified some proteins in the dermal basal layer. So in comes lymphocytes, all these little purple dots near. Lymphocytes are coming in to attack the basilar layers, the lower layers. So notice, I can't see a nice junction of the skin. You should normally see a nice dermal, epidermal junction, like over here, nice junction. But then all of a sudden it's like, okay, exactly where is it? This is called an interface. The interface between the epidermis and dermis becomes blurred by all the inflammation. So remember this term, interface dermatitis. And it's not specific just for this disease, but it's telling me that the inflammation is trying to get something in the basal layer. Now, what are these really pink cells here? Pink cell, shrunken, dark nucleus. Who are these little pink cells? These are the cells, the keratinocytes, that were told to die. These are little apoptotic keratinocytes. That's what those shrunken purple or shrunken pink cells with very dark purple nuclei are. Yeah, the T cells come in and say, sorry, your antigens have been modified by the drug. You need to die. You look different to me. So the immune system coming in, attacking the skin, probably because of the drug kind of modifying it. All right, now we got two more severe forms because this is the mildest form. So I'm going to put number 1 as the mildest form. Now, the intermediate form is called Stevens-Johnson syndrome. So this is kind of getting worse. Stevens-Johnson is when you have an extensive disease, so it's pretty much everywhere with a fever. So it's a more severe form, Stevens-Johnson. And again, we often hear this associated with drugs. It can happen with infections too, but we often see it with drugs. Stop the drug, stop the drug, stop the drug. Now the worst form, and this is the form you don't want, is called toxic epidermal necrolysis. Now I want you to think about that. Toxic, that's not good. Epidermal necrolysis, the skin is dying and falling off. Your skin is falling off. This is gonna be like a burn victim. Their skin literally falls off like a burn victim. You just lost your skin. You're at high risk for infection. This is very dangerous. So toxic epidermal necrolysis is the most fulminant and severe form. You see diffuse full thickness necrosis. So the T cells came in and told everybody to die. So the whole thing is necrotic and it sloughs off. Yeah, it just falls off. Not just the skin, but also mucosa. So in the mouth can blister and fall off as well. And it looks very similar to a burn, because you basically lost your skin in large patches that will undergo necrosis and the skin falls off. So it's like a big area burn. Now, one of the features we will see here is if I rub the epidermis, wherever I rub it, since the cells are dying, wherever I rub it, you'll get a blister. Wherever you rub it, blister, rub it, blister. Gets a fancy term, we call it Nikolsky sign. Nikolsky sign. So this is a sign of whenever I rub the skin, it falls off, it blisters, makes a blister. Now, is Nikolsky sign only for erythema multiforme? No. Scalded skin syndrome, where the skin looks like a burn is falling off, will have Nikolsky sign. And then there'll be another autoimmune disease. It's where you make antibodies against the desmosomes and your skin falls apart because no desmosomes to hold it together. That is going to be called pemphigus, pemphigus vulgaris. So there's 3 diseases in your brain you need to remember Nikolsky sign. So Nikolsky, rub the skin, I get a blister, a vesicle, a boa. So we're going to remember erythema multiforme, the most severe form called toxic epidermal necrolysis, it's falling off. Scalded skin syndrome due to staph, where staph is making toxins that break apart the desmosomes. And then finally, pemphigus vulgaris. Pemphigus, toxic epidermal necrolysis, and scalded skin syndrome. These are the 3 biggies. These are the 3 biggies where your skin is falling off. It's all weak, you rub it, you'll get a blister. Nikolsky sign. So now we got derrieres, we got dermatographism, and now we got Nikolsky sign. So these dermatologists have a lot of cool signs to look for. And again, this is why dermatology gets its own specialty. Like, John, I never heard of Nikolsky sign. Well, dermatologists know all about it. Family medicine? No, we're not looking for that sign. Right? We don't think of that kind of stuff. So that's why it gets its own specialty. That's why they get paid the big bucks. They gotta learn these different terminology and different signs. All right, now that finishes the acute. Now we gotta switch gears and turn to chronic inflammatory dermatitis. Now we got 3 in this category again. So 3 acute, 3 chronic. Psoriasis, which on a 5-star scale gets 10 stars. 10 stars. They love it. And then lichen planus and lichen simplex chronicus, which is simply chronic scratching. Scratch, 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 skin gets thick. So psoriasis is going to be your highest yield. We did talk about this one in the vulva. We saw it in the vulva when people were itching and itching, itching. And a new kind of cool one is lichen planus. But again, you only learn one, got one more brain cell to go, this is the one to know. They're going to ask about it. Now again, what do these have in common? Well, first of all, they're chronic. So these are going to last for months or years. They're not going to go away right away. They're going to come and they're going to stick around for a while. They're chronic. Number 2, under the microscopic, when you have chronic inflammation, what do you think the epidermis is going to do to protect itself? It's going to thicken. You're going to get thick skin. So we call that acanthosis, when the skin grows and gets thicker. So they're all going to have thick skin because it's chronic. They're all going to have hypergranulosis, so that granular layer is going to get really thick. Again, that's usually a sign of chronicity. So whenever I see a skin biopsy with a very thick granular layer, I'm like, well, whatever it is, it's been going on for a while. Another characteristic feature is they tend to get hyperkeratosis as well. So they get thick corneal layer gets very, very thick. Lots of the keratin will be there. So thick, sometimes scales. Like psoriasis has lots of silvery scales from all the keratin, the hyperkeratosis. Now, another problem with chronic is epidermis may grow for a long time, but then it may atrophy. So unfortunately, you may get atrophic areas when your skin will become very thin. Now, another characteristic feature of chronic inflammation is fibrosis. Inflammation heals with scarring. So getting some dermal fibrosis is very common when you have chronic inflammatory diseases. All right, but I want the money. Give me the most, I got the common clues. Give me the clues that I need for psoriasis. What makes it so special and so sexy? Let's go through it. Here it is. Psoriasis is very, very common. It's a chronic inflammatory condition affecting 1 to 2% of the population. Oh my! Now, can anybody tell me, what girl do you all keep up with has psoriasis? You all keep up with her because of her sex tape and her show? Who are you keeping up with? Kim, yes. So I'm now going to change her name. She's no longer Kim Kardashian. She's now Kim Kardashian. Because she came into the dermatitis with this rash, and I want you to see it. It's well circumscribed. Do you see it here? Well circumscribed plaques. They're plaques. It's thick skin. It's like plaque. Well circumscribed red plaques with silvery scales. And notice they were behind her knee. Behind her knee. Now, greatest field ever. I'm going to send you a link. When I send you these videos, I'm going to send you a link, and you can watch him diagnose her. I know you don't watch the whole episode, but I got a clip of just him diagnosing her. And you can watch. He walks in and goes, "Hi, Kim. What can I do for you today?" She goes, "Doc, I have this thing behind my knee. And let me see. Is that itchy?" "No, it's not itchy." "You got psoriasis." I mean, he never touched her. Watch, look, his hands are in his pocket. "I got my mind on my money and my hands on my money." That's dermatology. I got big bucks in there. I don't want my hands to leave that money. Great field. He doesn't even touch her. He's like, "It's not itchy. Red plaques, silver scale. You have psoriasis. Pay me. Pay me. Big bucks." Think about dermatology, please. Think about it. Yeah, if I had to do it again, I would have done derm. It's the greatest field ever because there's no emergencies. What emergency could you have dermatology? What, I have a pimple? That's a dating emergency, not a medical emergency, right? If there actually is an emergency like epidermal necrolysis, toxic epidermal necrolysis, go to the ER. Don't come here. Go to the ER. Unless it involves the skin, go to the ER. You need to go to like the burn unit anyway. Crazy. It's the greatest field ever. And when you're at the party, everyone loves you. When they hear you're a dermatologist, they want to show you their skin. They're like, "Hey, look, what's this thing in my butt?" And you're like, wow. Everyone wants to get naked for you. It's the greatest field ever, so consider dermatology. Everyone gets naked for you. All right, but anyway, it's a side story to tell you, man, dermatologists get paid. But sure enough, she had it. And do you know what the most common type of psoriasis is called? Psoriasis vulgaris. Vulgaris, vulgar behavior, sex tapes. She's naked like half her selfies. Yeah, vulgar behavior. So psoriasis vulgaris. Now question, does it run in families? Her mom's got it too. Her mom's got it too. So notice, it runs in family. It's associated with your HLA. It's associated. 2/3 of affected victims have HLA. Yeah, so her mother has it. She has it too. Does her daughter and sons have it? Maybe. You have a chance of passing it on because you get your immune system. You get your HLAs from your parents. So this is one of those things you can blame on your parents. You always blame your parents anyway. "Oh, Mom, because of you." Yeah, now you can really legitimately blame your parents because that's where you get your immune system from. Now, just because you have the right HLA, does it mean you're going to get the disease? Heck no. If you have the right HLA, it means you're at risk. You have to be exposed to something in the environment. And that will trigger, if you have the right HLA, that will trigger an immune response. And what you're going to see here is you're going to see T cells. So CD4 T helper 17, T helper 1. You're also going to see CD8 cells coming in too. They're all going to accumulate in the dermis. Wow, so you're attacking your own skin. Some people say at first she wasn't very comfortable in her own skin. Maybe it's true. So T cells are coming in, and CD4 helper T cells and CD8 cytotoxic T cells are coming in. And they're going to make a lot of inflammatory cytokines and growth factors, and that's what's going to cause the epidermis to thicken. So she's going to get very thick skin. Yeah, so first she was uncomfortable in her own skin, and now she has very thick skin because no matter what she does, she never seems to be embarrassed by anything. So she really has thick skin. Interesting. All right, now some associated features. Whenever there's a chronic inflammatory disease, inflammation leads to atherosclerosis. So anybody with a chronic inflammatory disease like rheumatoid arthritis, lupus, psoriasis, they have an increased risk of heart attacks and strokes because it's a chronic inflammatory condition. Do you remember we talked about lupus? We talked about, we got good drugs. We now have hydroxychloroquine, which is an anti-malarial. We've got steroids. We have immunosuppressive drugs. We have lots of good drugs for lupus. So now people are living, but they're still going to die early from MIs. Cardiac disease seems to be the rate-limiting long-term survival problem for people with these inflammatory diseases. Not cool. Now, she may also be at risk for arthritis. What HLA? Well, we haven't done this yet, but HLA B27. If they're B27, HLA, because I don't know her HLA, but B27 patients are at higher risk for getting a psoriatic arthritis, or maybe even ankylosing spondylitis. She's potentially at risk for that as well. So again, if she has that HLA, in addition to this HLA, the psoriasis HLA, she's at risk for getting psoriatic arthritis and ankylosing spondylitis. Yeah, I always remember B27 and arthritis. B27 and arthritis, that's a big risk factor. All right, what else? This is one of the causes of erythroderma. What is erythroderma? The entire body gets inflamed and gets redness and scaling. So this is one of the causes. Another cause is mycosis fungoides. Mycosis fungoides, when it spreads and becomes sesaries, now it's in the blood. So now you can get a rash over your entire body, a scaling plaque-like rash all over your body. That's another cause of erythroderma. So again, there's not too many diseases that cause the entire body to get red. Psoriasis is one of them. Now, in most cases, though, it's local. It's more local disease. It's usually on the extensor surfaces of like your elbows, your knees, your buttocks. I know, gentlemen, buttocks. Your scalp, because when you lay down, it's usually pressure points and usually extensor stuff. All right, now the nails are also affected. So nail changes, you can often get separation of the nail coming off the bed, so that's called oncholysis. You can also get pitting, and this is a favorite picture on step 2. They love to show fingernails, and it's pitted. It's little pits, like holes, little pits in the nail, and often like a brown, oil-like discoloration. It's brown like oil, like an oil color, brown discoloration. It's okay, she wears fake nails anyway. But if you actually looked at her nails, they might be pitted and have discoloration. Now, unfortunately, interleukin-17 calls in neutrophils. So if there's a lot of interleukin-17, you could get so much neutrophils that your plaques will have pus. They call it a pustular form of psoriasis. Now, that's not good. I have plaques, red plaques, that's embarrassing enough. Now they're pussy red plaques? Ooh, yikes. So that's a very severe form. We often have to do a more aggressive treatment for that. And again, interleukin-17 calls in neutrophils. So whenever you see neutrophils in the skin, think interleukin-17 from the T helper 17 cells. They make interleukin-17 calls in neutrophils. All right, now let's look at some of these pictures. What does it look like? Well, we saw the red plaques, usually on the pressure points. So for her, it's behind her knees because she's often on her knees. That's a pressure point for her. But elbows very common site, buttocks common site, and scalp common site. Now here's that favorite step 2 picture. Does it look like pits? Literal pits, little holes, pits in the nail. And then notice over here it's kind of a brown discoloration. Some people would say it looks like oil. It's not oily, it doesn't feel oily, but it looks like brown, like oil. So an oil color discoloration of their nail bed. So those are characteristic nail features that you'll see. Now, here's what you need to recognize for USMLE. Pressure points, elbows, right? Rubbing elbows, buttocks, because you sit on your buttocks when you sleep at night. Your scalp will get these plaques too. Pressure points, that's where they occur. So extensor surfaces, usually pressure points. Elbows, where you put your elbows down, your knees, scalp, buttocks, these are the common sites. Now here's the description. They are well demarcated, right? You could see where that starts and ends, right? Very well demarcated plaques, and they're red. They're erythematous. It's inflamed, red, swollen, plaques, elevated, plaque-like. Yeah, very well demarcated. Some people say they look kind of like salmon color. Yeah, like a pale red, red-orange. So salmon-colored plaques, and on the surface is this white stuff. This is called the silvery scale. Yeah, it's white like silver. They call it the silvery scale. Yeah, so kind of scaling. Because of the thickening of the skin, there's so much keratin and parakeratosis that it starts flaking off like this. Looks like silvery scales. That's the classic description. Now remind me, if this is on your scalp, what are these silvery scales going to look like when they flake off? What are these little white flakes going to look like in your scalp? It's going to look like... Anybody know what that's called? It's called dandruff. Yeah, you bet. So they often have to airbrush her pictures because some of these flakes will come off her scalp onto her shirt. So if she's wearing something dark, they have to airbrush it to get rid of it because it looks like flakes. It looks like seborrheic dermatitis, which is dandruff. It looks like dandruff. Yeah, flaking off the scalp. Now, what if I grab those white things and I pull it off? Well, if you pull it off, you will get pinpoint bleeding, little red dots, pinpoint hemorrhages. And this gets a fancy word. If you pull off the scale and there's little red hemorrhages, petechial hemorrhages, they call it Auspitz sign. Now, a buddy of mine said there's a very naughty mnemonic here, so I'm not sure I should say it. He said it, so you're going to blame me, but if he said it, he said, well, Kim Kardashian. Hey, Kim Kardashian, oh, she spits, Auspitz sign. So I was like, okay, I don't need to know that. But yeah, that's one way to remember Auspitz sign and psoriasis. See, if we relate it to famous people, you always get it right. Now, why are they getting these punctate bleeding if you pull off the scale? Here's why. Under the microscope, notice how thick the epidermis is. So it basically goes from here down to here. It's very thick. That's called acanthosis. So very thick epidermis. Number two, look at the keratin layer. It's very thick. This keratin layer is very thick. And notice it's kind of peeling off. It's flaking off from the skin. So here's the epidermis. It's flaking off. That's the silvery scale. Right? Silvery scale. Notice a lot of purple nuclei in there. Purple nuclei. So there's a lot of parakeratosis. So hyperkeratosis and parakeratosis. Very, very common. And that's what creates that scaly appearance. Now, what if I pull it off? If I pull off the silvery scale, I'm going to pull off a little bit of the epidermal surface as well. Notice, the dermal papillae come way up. So little blood vessels, which are down here in the dermis, these blood vessels are going to come up and then come back down and come up and come down. These blood vessels are going very high. So when I pull off this little superficial epidermis, I'm going to have hemorrhage right there. I'm going to have pinpoint hemorrhage there. These little punctate pinpoint hemorrhages, that's the Auspitz sign. When you pull off that silver scale, you're going to pull off the thin parts where the dermal papillae go way up. Now tell me, what do you call when the epidermis goes way down? Well, these are called reedy ridges. Reedy ridge, reedy ridge, reedy ridge. So the dermal papillae are going way up. The reedy ridges are coming way down. In fact, some people will say these elongated, they're really long reedy ridges, kind of resemble test tubes. Like if you're in the lab, it looks like a test tube, test tube, test tube. It looks like a bunch of test tubes sitting in a rack, right? A test tube rack. So test tube, test tube, test tube. That's how they often describe it. Because normal epidermis, let me go back and just show you. The reedy ridges should not be like this. Let me go back. This one, you can't see the junction. Let me go back to something relatively normal. That one's too inflamed. Here, this is better. Here's a dermal papillae, right? Here's a reedy ridge. Here's a reedy ridge. They're not that long, right? The dermal papillae doesn't go that high. I mean, this is really thick skin where the reedy ridges went way down and the dermal papillae went way up. So very thick skin. All right, but there's a characteristic feature coming our way. So we saw the test tubes in a rack, these long, long reedy ridges, but up in the corneal layer, corneal layer, we have a lot of parakeratosis. Do you see these purple collections here? See this purple collections? See that? Those are neutrophils. I wish we could go closer to see that, but these are neutrophils. These are real micro abscesses, because you can't see them with your eye. You need a microscope to see these. What you'll see with your eye are these white flakes. But under the microscope in these white flakes in the keratin silvery scale layer, you're going to see collections of neutrophils. Again, because of interleukin 17. So let's put this here. The T helper 17 produced interleukin 17, and that's what calls in the neutrophils. So the T helper 17 produces interleukin 17. and that calls in neutrophils, and you get these Monroe's microabscesses. Now, the way to remember this is, who does Kim Kardashian think she is? Because she's so curvy, who does she think she is? She thinks she is the brunette Marilyn Monroe. And now she is. She's got Monroe's microabscesses, Marilyn Monroe's microabscesses. So you can't miss it. Marilyn Monroe's microabscesses. Now I want to stop for a second. We have two microabscesses in the skin. We have Monroe's for psoriasis. And do you remember we had Portier's? Portier's microabscesses, which really weren't microabscesses, they were malignant T cells. That was mycosis fungoides. So let's not confuse the term. Portier's, that was the T cell one. Monroe's, well, that's Kim Kardashian. She's got psoriasis, right? Psoriasis. She thinks she's the brunette Marilyn Monroe. Man, I love this. Kim Kardashian. Can't miss it, can't miss it. All right, now, here's an interesting feature. Do you remember we had Nikolsky sign where you rub stuff and you got a blister? Well, now we have Knobner's phenomenon. Knobner. Well, this is where if I scratch the skin of this affected psoriasis patient, they'll get a plaque wherever you scratch them. If you scratch them, you'll develop a plaque there. So it's kind of similar to Nikolsky's. Nikolsky's was a blister where we scratch them. Here is a psoriatic plaque. You'll develop a psoriatic lesion, a plaque, wherever you get locally traumatized. Wherever I scrape your normal skin, that's why pressure points. So when they're on the elbows, they're going to have little trauma, micro trauma, and they get the plaques there. Or the buttocks, very common. Yes, I know, gentlemen, it's on our buttocks, right? Not very pretty. But yeah, that's pressure. Every day we're sitting on it, right? Some more than others. All right, so very important clue. Now let's go to treatment. This is very easy for the board to test because there's lots and lots of treatments. Now, obviously, it really depends, is it local or is it more widespread what treatment we'll do? If it's very local, we'll start with topical agents. Let's put some vitamin D, some vitamin A, try to make it mature. So vitamin D and vitamin A are often topically applied to these plaques, can help the skin mature and stop getting so thick like this. Tar preparations, so things with tar-based. I know, some people say she should be tarred and feathered. She should be tarred and feathered. So you can use these tar creams or tar shampoos for the ones on your scalp. And obviously we can also use topical steroids. Now tell me what the problem is for using long-term topical steroids. Why would I not want to do that long-term? I'll do it for a short period of time, but why not long-term? What will topical corticosteroids do to my skin? What will they do to it? Yeah, they lead to atrophy. You're going to get thin, atrophic skin. Not cool. I don't want my skin to become paper thin. No, 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 no. So we try not to use long-term topical steroids. So if it's a local plaque that occurs, and again, these are chronic, but they go away over time. So we'll put vitamin D, vitamin A, tar creams, and you might want to try a course of topical steroids until it goes away. Now, if it's more widespread, well, then I can't do that anymore. If it's more widespread, I'm not going to put steroids all over your body. I'm going to use light. So ultraviolet phototherapy, it seems to affect and stop this disease. Phototherapy. Now we can either use narrowband UVB, or if we use UVA, we have to sensitize your skin by putting a chemical on it first. It's called Sorelens. So we call it PUVA. Sorelens and UVA light. PUVA. So if you ever heard of PUVA therapy, that's what they're talking about. A chemical called Sorelens is put on the skin first because that will sensitize it to UVA. So either just use UVB or use Sorelens with UVA. This is a very effective therapy. Now another therapy that's also first line would be methotrexate. Methotrexate. So if it's severe case, first line, start methotrexate, not a bad case. But again, that's a chemo drug, right? So for severe cases, we can use that. But for very local cases, you won't want to do that. Now, what else could I do? I could do immunosuppressive agents, like cyclosporin. But again, that's going to suppress my immune system really severely. So these are our options. First line, we can use phototherapy, methotrexate, or immune suppression. So we kind of like the light one, right? Shine some light on me for a while, and then when it goes away, you stop the light. Methotrexate is also very effective, but unfortunately it is got a little bit of toxicity here. It's a chemo drug, right? And of course, immunosuppression, lots of problems with that, but you may have to use it for severe cases. So again, this is our first line. First line. All right, now, what if it doesn't respond to first line? Oh, well, then you're going to go to some of the second line drugs. Now, I forgot to mention, what's causing this disease? It's going to go back here, go back here, go back here, go back here. Okay, what's causing this disease are these inflammatory T cells. They're making cytokines and growth factors. Let me just list some. Some of the cytokines, they're going to make interleukin-1, tumor necrosis factor, alpha. They're going to make interleukin-17, that's what causes the neutrophils to come in. So these are just a couple of the cytokines that they're going to be involved from these T cells. Interleukin-1, tumor necrosis factor alpha, interleukin-17. Interleukin-17 is what can cause the pustular form, and it also is accounting for that neutrophil Monroe's microabscesses. But look at this one, TNF. TNF, this is a major mediator of this inflammation. So we now have invented TNF inhibitors. Never first line. This is second line, either for very severe cases or for cases that do not respond to primary therapy. We will use TNF inhibitors. Very sexy and very testable on exams. If I was writing an exam, this would be top of my testing for psoriasis. TNF inhibitors. Some examples are a monoclonal antibody called infliximab, another monoclonal antibody called adalimumab. Oh man, I feel like I'm stuttering. And how about etanercept? This is not monoclonal, but it also is a TNF inhibitor. It's not monoclonal though. Okay, so we got a bunch of these TNF inhibitors, and they're very effective for the severe form. So like pustular, that was a very severe form. For chronic plaque psoriasis that does not respond to anything else. It can also help with arthritis. If you have a very severe case with arthritis with it, it'll help the arthritis get better too. So very effective drug. Now, when do we use TNF inhibitors on the exam? Never first. Never first. These are second line drugs. If the first line doesn't work or it's super severe, you may have to add these to your first line. Now, I want you to remember, we use this drug for refractory cases of psoriasis. We use it for refractory cases of rheumatoid arthritis. And we use it for refractory fistula-forming cases of Crohn's disease. So Crohn's disease with fistulas usually. Okay, so again, there's 3 times they've approved TNF inhibitors for use on FDA approval. It's severe refractory psoriasis, severe refractory rheumatoid arthritis, and severe refractory Crohn's disease, that usually the fistula-forming Crohn's, the ones with a lot of fistulas. It really works well to heal up those fistulas if you get rid of the TNF inhibitors. Now, why is this going to be so tested? Because it knocks out the ability to make granulomas. You need TNF to maintain your granuloma. Okay, so I need 2 things to make a granuloma. I need interferon gamma to make hulks, and then I need TNF to maintain the granuloma. TNF is for maintaining it. So if I can't maintain granulomas, what disease is going to run rampant? TB. So very testable. Before you start infliximab, before you start it, you gotta check for TB. So you gotta do a PPD, do a chest x-ray, make sure there's no TB. Because if the board says we start infliximab, and then 2 weeks later they have shortness of breath and multiple lesions in their chest x-ray, the answer is miliary TB. It reactivated and now it's miliary. It's spreading all over the place. All right, so very important to remember this. Now again, I like to always have drug names mean something for me. So when I look at infliximab, the first 3 letters almost look like TNF. Looks like TNF. So mab is monoclonal antibody, TNF against TNF. This one, Abdullah. It sounds like it might be a Middle Eastern drug. I don't know. Abdullah. I don't know. I'm not sure how to remember that one. All right, etanercept, I don't know how to do that one either. Here's T in it. Here's TN. It intercepts. Couldn't you call it TNFicept? TNFicept? That would have been good. But anyway, sorry, I can only help you remember this one. But you gotta know these drugs. They really like it in pharm. By the way, how was your pharm exam? Was it tolerable? Or did it make you tear? You don't want to say, meh, meh. Trust me, when I was in pharmacology class, oh man, that was the dread of my existence. I really thought I would not make it to third year because of pharmacology. I was really like, I'm gonna quit. Because it was just a list of drug after drug after drug, and no one to explain it. Like you have Dr. Z to explain some of it, kind of like make it at least palatable. Oh man, my teacher just read the drugs. He just read the list and said this one does that and this one does that, and no way to help remember. Oh, it's giving me nightmares and flashbacks. All right, one last thing. We'll take a break. They're working on new agents to inhibit the T helper cells. So that would be pretty good in this disease too. Knocking out TNF is very important, but knocking out some of these other inflammatory molecules would be pretty good too. And that's the future, you guys. You guys are working on great ways to stop the inflammation, stop the immune system from causing diseases. We're coming up with new anti-inflammatories all the time. When I was in med school, it was just NSAIDs and steroids. Done. That's all we had. Now you got cyclosporin, you've got like a million anti-inflammatory drugs that you need to know. I know, every year, more drugs. All right, perfect place to take a break. We'll come back, we'll pick up more of these chronic lesions. I'll see you in a few minutes. All right, gang, hour number 2, so far so good. Picking up lots of points. That psoriasis was a big one. Lots of points. Kim Kardashian has it. 1% population. And again, the most common type is called psoriasis vulgaris. That's the worst type. That's the most common type. Well, it's not the worst type, but it's the most common type. One of the worst types is chronic plaque type and pustular. Those are very bad forms. All right, now let's talk about next one is called lichen planus. Lichen planus, plain, like a plain, a plateau. Now we often use a little mnemonic here. We use the 6 P's to describe this disorder. It is pruritic, it's itchy. Remember, psoriasis wasn't itchy. This is itchy. So it's pruritic, it's itchy. It's purple, so pruritic, purple, purple color. It's polygonal. It's like polygons. Look at this one. They kind of like this way, this way. This one almost looks like home plate, doesn't it? It's almost like home plate or like an upside down house. It's polygonal. So itchy, pruritic, purple, polygonal, planar. So it's a papule, but it's like a plane, and or like a plateau. And plaques. It can be plaque-like. So papules and plaques. Purple, pruritic, purple, polygonal, planar, papules, and plaques. Good gravy. That's like a tongue twister. That's like a medical tongue twister. So that's how we often describe it. So purple, it's kind of itchy. It's like a plaque. It's like a polygon in shape. These are the key features. Now, who gets it? Usually middle-aged adults. Usually occurs in the extremities. And it's self-limited. It just comes, we don't know why, and it goes. So spontaneous resolution, usually in 1 to 2 years. So it's chronic. It doesn't go away right away. It sticks around for quite a while. But it's self-limited, doesn't go away. It's itchy, it's purple, violet, flat top papules. They can coalesce to make a big old plaque, a very large lesion. It's often symmetrically distributed on the extremities. Now, what are we going to see under the microscope? We're going to see an interface dermatitis. Now, wait a second. We've seen that before, so it's not unique, right? So interface dermatitis, you're going to see CD8 T cells coming in to attack the basal layer again. Now, what are we going to see under the microscope? Number 1, epidermal hyperplasia. So the skin starts getting thick. So from here to here starts getting thick. We see hypergranulosis. Look at the thickness of the granular layer. It's pretty thick here. It's a pretty thick granular layer. We're going to see hyperkeratosis, another sign of chronicity. So these are signs of chronic, thick granular layer and thick keratin layer. All right, now you're going to see a dense lymphocytic infiltrate at the dermal-epidermal junction. That's the interface dermatitis. So lots of purple nuclei down here. Lots of purple nuclei kind of messing up the junction. Hard to see where it starts and stops in this area. Over here I can see it, kind of. It's pretty good over here. And then here it's like jagged. It's kind of hard to see exactly where it is. So this is the area of the interface dermatitis. Now I want you to notice, in this area, it's kind of like a sawtooth. It's like a tooth on a saw, right? That sharp tooth. That's how they often describe the epidermis. It's kind of hard to see where it starts and stops, but it does look sharp like a tooth, a sawtooth. So that's the classic buzzword for this one, sawtooth appearance. Sawtooth appearance. So thick skin, interface dermatitis with a sawtooth appearance. And then of course the T cells are coming in and they're causing apoptosis, but we give it a fancy name. We call them colloid or sabbat bodies. Colloid or sabbat bodies. Now let me see if I can take a look in here. Is there anything that I can see for sure? Oh, there's a sabbat body right there. That pink one is really shrunken and dark. Let me see if I see any other ones. Yeah, this is probably another one here and another one here. Those are your sabbat bodies. Now, honestly, it looked like the other interface dermatitis too. They had similar things. They just don't call them sabbat bodies in the other case. They only call it sabbat bodies here. So it's kind of frustrating, but that's what they do. So look for sawtoothing. You see the sawtooth appearance with the apoptosis, then you call them sabbat bodies. Sabbat bodies. Okay, so we've got sawtooth with this interface dermatitis. All right, but really the key is looking at it as polygonal purple plaques that the patient's like, what is this? It's itchy. What is this? Bothering me. It's itchy. I don't like it. This is lichen planus, lichen planus. Now, one more thing. You see the hyperkeratosis? This thick stuff? It's going to look white. So if you look at the surface, it kind of looks white, but it's kind of lacy. It's not uniform white, it's lacy white. So that gets another name. They call it Wickham stria. Wickham stria. This white lace-like markings on the surface from the hyperkeratosis. So it looks lacy, this white stuff on the surface. Lacy. All right, that's lichen planus. Is it super high yield for exams? Not super high yield, but you should definitely recognize it. Purple polygonal plaques, they're itchy. Under the microscope, there is interface dermatitis with a sawtooth appearance of the epidermal-dermal junction and sabot bodies. Boom, lichen planus. All right, now this one we've actually seen before. Lichen simplex chronicus, it's simply chronic scratching which causes the epidermis to undergo hyperplasia. So kind of a newer term for it would be just hyperplasia. So squamous hyperplasia is a more, it's a kind of a better term, right? Now these are going to look raised, they're going to look scaly and red, and they're going to be very rough skin. Sometimes they get so thick they become white. So white or scale-like. It's usually repetitive local trauma. So constant scratching or rubbing on a particular area. Just keep scratching, and you'll get these elevated red scaly plaques. Under the microscope, we're looking for thick skin. Acanthosis, very thick skin. So if we start at the top, go down, it is very thick. Very thick. We've got hyperkeratosis and hypergranulosa. Kind of hard to see the granular layer that well here, but this more purple layer down here, this kind of surface here, is a little bit thicker. We see elongation of the reedy ridges, similar to what we saw in psoriasis, so they're really elongated. They're not quite thin like test tubes like we saw before, but they're elongated. That's a little bit similar. So thick skin, elongated reedy ridges, some hyperkeratosis on the surface. And in the dermis, you can see a little fibrosis and inflammation. So a little bit of inflammatory cells here, a little bit of inflammation. In the lower papillary dermis here, right below the epidermis, below it is the papillary dermis, and that's where we see the inflammation. So again, stop scratching, and the skin will go back to normal. It's just chronic irritation, no big deal. Again, remember the vulva area. All right, now we're going to switch gears. We did acute inflammatory, we did chronic inflammatory. Now we're going to do blistering skin diseases that are characterized primarily by coming in with blisters. Again, if they're small, you call them vesicles. When they get big, we call them blisters. Now, all three of these are autoimmune. All three are autoimmune. So these are the autoimmune blistering skin disease. And what does a pemphigus mean? It means bubble. Because we're going to have pemphigus, we're going to have pemphigoid. Pemphigus, pemphigoid. Pemphix means bubble. Yeah, bust you like a bubble. So you're going to see these bubbles on your skin, these blisters. Now, here's the difference. They sound the same. Pemphigus, pemphigoid. Well, there's a big difference. Well, they both have IgG. That is in common. So they're all autoimmune. So the first one is IgG. Next one is IgG. Now the third one, dermatitis herpetiformis, is totally different. It's got IgA. So right away, that's very different. Because the way we're going to diagnose these diseases is we're going to do a skin biopsy of these blisters. You come with these blisters, we're like, what's going on? We biopsy the blister, and we're going to do what's called immunofluorescence. We're going to fluoresce to look for the antibodies. And that's diagnostic. What's fluorescing and the appearance? What does it look like? Is it a line? Is it granules? Does it look like a fishnet? That's the key. The immunofluorescence pattern will be diagnostic. So again, to diagnose these, we're going to do a skin biopsy, immunofluorescence. The first two have IgG, but they have different patterns. The last one is IgA. You can't confuse it. So really, the one that students are going to confuse is pemphigus and pemphigoid because they sound the same. In fact, I bring my residents in. I bring them in and say, come on, sit down. Pemphigus, pemphigoid. What's the difference? And they're like, blistering skin? I'm like, yes, but what's the difference? IgG? Yeah, they both have IgG. Which is IgG against desmosome? Which is IgG against hemidesmosome? All right, just tell me which one is antibodies IgG against desmosome. It's pemmican. Did you say pemphigus or pemphigoid? Yes, that's what I said. They don't know. I know they don't know, and they're trying to get over on me. So I want you to be better than most students because they memorize it, gone. Memorize it, gone. So I want to kind of tattoo this to your brain, so on the boards, and more important on the wards, you'll actually remember the difference without having to look it up every time. So I'll try to make it silly, because they do sound the same, and they both have an IgG. So we're going to see what's different. All right, now I put this little table here to kind of compare and contrast. What is the cause? What is the effect? What is the age group? What is the sex? What is location? They're all going to have blisters, but where they're located. Where is the blister located on the biopsy? And of course, the gold standard for distinguishing is the immunofluorescence pattern on the skin biopsy. That column you're going to need for sure. That row, I should say, that going across. You need to know that for sure because it distinguishes with certainty. Now let's start with the first one. The first one is called pemphigus. The most common type is called vulgaris. There are going to be other forms though. There's going to be follicularis and there's other forms too. But vulgaris is the most common, counts for 80% of all cases. Now, what does vulgar mean? Oh yeah, bad words are coming out of your mouth. So that is a key distinguishing feature. This is the one that has blisters in the mouth. The other two have blisters on your skin, but not in your mouth. So kind of helpful to remember pemphigus vulgaris, because that'll tell you vulgar words and blisters in your mouth. That's a key distinguishing feature, blisters in the mouth. The other ones don't have that. All right, now what's causing it is IgG autoantibodies against desmoglein 3, which is part of the desmosome. Oh, I got it. So I'm attacking myself. I'm attacking my epidermis. Here's my squamous cell. I'm attacking the desmosomes that hold the squamous cells together. So what's going to happen to my epidermis if I lose intracellular adhesion? They're going to fall apart. There's a term for that. When the keratinocytes fall apart, they lyse. We call it acantholysis. Makes sense? If you're going to destroy the connection between my cells are now going to lyse apart. And that's why you get a blister. You're going to get a blister within the epidermis because the epidermis is falling apart. It's falling apart. Okay, so you get intraepidermal blisters. Where in the epidermis? Well, it depends. If it is vulgaris, it's usually right above the basal layer. So pemphigus vulgaris is the one that usually gets supravascular. Pemphigus follicularis, which we'll see in a minute, has it much more superficial. So it'll be in the granular layer. Okay, so it really depends because there's different desmosomes at different layers. Okay, so there's always desmosomes, but some have desmoglein 1, some have desmoglein 3. So it really depends on which the antibody is against. In vulgaris, it's desmoglein 3, and that's towards the lower part of the epidermis. But the key is intraepidermal lysis. The skin is falling apart. It's falling apart. So what if I rub it? What if I rub it? It'll fall apart. You'll get a blister wherever I rub you. Do you remember that was called Nikolsky sign? This is the one that has Nikolsky. Nikolsky. Now again, it's not 100% diagnostic, but it will separate this disease, pemphigus, versus pemphigoid, because this does not have Nikolsky. So it's a great way to tell the two apart. Makes sense? The epidermis is falling apart. When I rub it, it's going to make a blister because the epidermis is literally falling apart. So Nikolsky sign is a very important clue here. All right, now who gets this vulgar disease? Well, it's usually middle age, often Jewish, Mediterranean Jewish, often. Males equal to the female. So middle-aged people come in, and thank goodness it's rare. It's rare because it's usually lethal. It's lethal. It will kill. This is a killer. This is a bad one. Why? Because it's superficial. When it ruptures, it's superficial. It's going to rupture easily. When it ruptures, you're going to get infected because it's superficial. If it's deep, it wouldn't rupture. If it's superficial, epidermal, they're going to rupture and you're going to get infected and you're going to die of sepsis. So thank goodness this one's rare because vulgaris is going to kill you. It's bad. You don't want this one. Now, where does it occur? It occurs in the mucosa of the mouth, so that's important. Vulgar words are coming out of your mouth. The other ones don't have that. And, of course, in the skin, especially on the scalp, the face, axilla, groin. It could be anywhere you got pressure. You got pressure because that's going to make damage and it'll pull the skin apart and you'll get blisters. Make sense? All right, now let me look at a couple of pictures here before we do the diagnostic feature. Okay, I want you to notice, this is my epidermis. Notice towards the top we have more desmoglein 1 in our desmosomes. Towards the bottom layers, that's where we have desmoglein 3. Now again, pemphigus vulgaris is antibodies against desmoglein 3. That's why it's going to fall apart here. When you damage these desmosomes, these cells fall apart, and you're going to get a blister right about here in the skin. Okay, so that's going to be pemphigus vulgaris. Intraepidermal blisters in the lower portion of the epidermis, falling apart. All right, now what about bullous pemphigoid? Well, that's the next one in the notes, and that's very different. That's making antibodies against the hemidesmosomes. Now, the hemidesmosomes are only down here. Hemidesmosomes attach the keratinocytes to the basement membrane. Here they are. It attaches the basement membrane, the laminin, to the cell. It attaches them. So if I mutate bullous pemphigoid, or I make antibodies, make antibodies against the hemidesmosome. Specifically, it's against the bullous pemphigoid antigen 1 and bullous pemphigoid antigen 2. If I make antibodies against them, the hemidesmosomes are now defective. So what will the epidermis do? It won't attach to the dermis. The epidermis will literally fall off the dermis. Isn't that cool? It'll separate. So the epidermis is here, and the dermis, now there's a blister. There's a blister in between. So you're going to get a blister here. Here. As the epidermis lifts off the dermis, you'll get a blister there. But notice, the entire epidermis is intact. So you're going to get a very strong blister that's not going to rupture. You're not going to die. Because it's deep. It's deep. It's the whole epidermis that comes off. And the epidermis is intact. It's not going to rupture. So that's why bullous pemphigoid is a better disease. Because the blisters are so deep and the epidermis remains intact. So you get a vesicle, a blister, but it doesn't pop. So you don't get infected. So boo, hiss, pemphigus. Boo, hiss, pemphigus, boo, hiss, pemphigus, bad, bad, bad. Pemphigus, it's superficial blisters. It's superficial blisters. It's superficial. You're going to get infected because it's going to rupture and you're going to die. Now, pemphigoid, oi, I'm old. Oi, I don't like it. Oi, it doesn't rupture. Oi, I don't die. So oid, notice, oid usually occurs in the elderly. It's a fairly common disease. It's much more common than pemphigus. And it's good because they don't die. They don't die. They can live a long life. So it's kind of just more of annoyance. It's like, oi, I'm old. Oi, I got blisters. Oi, I don't die. That's how I remember it. I let the name tell me the answer. Pemphigus, boo, hiss, superficial, ruptures easy. You get the Kolskis, it ruptures easy. Pemphigoid, oi, I'm old. Oi, I don't die. Oi, I follow my wife to the mall. Oi, I live my life. So that's just a fun way to remember. It's deep. Pemphigoid, deep. Epidermis separates from dermis because it's against the hemidesmosome. In the hemidesmosome, the IgGs are attacking bullous pemphigoid antigen 1 and antigen 2. That's the target, that's the antigen. Now tell me, What type of hypersensitivity are both diseases? If I know the exact target, this is desmosome, desmoglein 3, this is hemidesmosome, bullous pemphigoid, this is clearly type 2. These are both type 2 hypersensitivities. That's kind of testable too. That's testable. Okay? And again, the skin does not fall apart here. No lysis of the skin. The skin is intact. So it's not going to rupture. You have to push these blisters really hard to rupture them, because the skin, the epidermis, is not falling apart. It's just separating. It's not falling apart though. Now this usually occurs in the thighs. Ooh, the inner aspects of the thighs. Eesh. They can occur in the forearm, the axilla, the groin. I don't want to see blisters in between your thighs. Inner thighs, nasty. But notice, no mouth. No, vulgaris. It's in the mouth. The blister is below the epidermis. That's why it doesn't rupture. Okay? All right, now let's look at some more pictures here. Make sure we can tell these apart. Here's a nice picture. Here's vulgaris. Notice it's separating here. You're getting a blister right here in this lower epidermal area. So it's the low intraepidermal area that seems to fall apart. Acantholysis. So these poor squamous cells are just floating around, not attached to anybody because their desmosomes are gone. We call this acantholysis. These are acanthocytes floating around. Now tell me, why is the basal layer still intact? Why are these basal cells still sitting there all happy? Well, because what's not being attacked here? It's the desmosome, not the hemidesmosome. The hemidesmosome is okay. So I want you to notice, these basal layer is still intact. We give this a fancy name. We call it tombstoning. It looks like you're in the cemetery and there's a row of tombstones, doesn't it? It's like rest in peace because pemphigus is going to kill you. They call it tombstoning. Rest in peace. Tombstones. Yeah, that lower layer is still intact. So isn't that cool? Pemphigus killer. There's your tombstones. Tombstones. It's a killer. Tombstones. Now, bullous pemphigoid. Notice the epidermis is intact. The epidermis is fine. It's pulled together. It's all good. But it's separated from the dermis. It literally separates. So you get a blister between the epidermis, which is intact, and the dermis. So it's as deep. It's subepidermal. It's not going to rupture. You're not going to see Nikolsky sign here. You only see Nikolsky sign in this one. This is the one that's the Nikolsky sign. Yeah, it's like a Russian hitman. I'm Nikolsky. I'm Nikolsky. Tombstones for you. You don't like the vulgar words that are coming out of my mouth when I drink too much vodka? I'll put a hit on you. So that's how I'm going to remember it. Nikolsky, the Russian hitman. Blisters coming out of the mouth when he drinks too much vodka? Bad words, vulgaris, vulgar words come out of his mouth. You don't like what I'm saying? Tombstones for you. Tombstones for you. Now, the only thing that will save you is if Natasha walks by. Natasha, they're all hot, right? Natasha walks by with fishnet stockings. John, what are you talking about? Well, when you biopsy, we're going to do immunofluorescence. You're going to find IgGs where? Well, they're around each cell, right? The IgGs are around each cell. They go around each cell to kill the desmosomes, right? They're around each cell. So what does it look like if it's around that cell and around that cell? It literally starts to look like a net. So they call it IgG in a net-like pattern, like fishnets. So the only thing that will save you is if Natasha walks by, Natalia walks by with fishnet stockings. So again, make it silly. Pemphigus, boo, his Russian hitman. You don't like the words, the vulgar words coming out of the blisters in my mouth when I drink vodka? Well then, tombstones for you. The only thing that will save you is if Natasha walks by with fishnet stockings, then I'll forget my head. I need to go hit something else. So that's the only thing that'll save you. Now I'm making a joke here, but this is a terrible disease. Because how do you treat autoimmune diseases, doctor? How do you treat autoimmune diseases? Steroids and immunosuppression. Steroids and immunosuppression. Tell me, what are they dying of? Oh, they're dying of infection. So if I put you on steroids and immunosuppression for your autoimmune disease, your infection's going to kill you. So the one thing that will treat the disease will kill you? Yeah, because they got these vesicles that rupture, they're going to get infected. They die of infection, they die of sepsis. So what you have to do to treat this thing is you need to treat the infection first, very rapidly. And if you can stop the infection, get rid of the infection, then you could start the steroids and immunosuppression. But the problem is, until you treat the disease, you keep getting blisters. They keep getting infected. So it's like a catch-22. The thing that will save you is the thing that will hurt you. So the treatment for both of these, pemphigus and pemphigoid, since they're both autoimmune, is steroids and immunosuppression. But pemphigus does very poorly because when I put you on steroids, the infection gets worse. Got to treat the infection first. Hope you make it through, so I can start the steroids. Boo, hits. Now here are some pictures you should recognize. Notice, where's the blister? Where is it? Where? It popped. It's very hard to find ones that are intact. All the blisters, this was a big blister, but it popped. And now you're left with this eroded area, and it's going to get infected. Your skin looks like it's all open. Exactly. Vesicle pop. Yeah, so bullet that rupture easy. It's hard to find a picture of them because they usually come in when they're all ruptured. They're going to tell you, Doc, this was a blister, and it popped. That's what they're going to tell you. Now, if I rub the skin, if I rub it over in the normal area over here, well, if I rub it in an hour or so, you'll get a blister. That's Nikolsky sign. Now, if we take a look at this picture, I think you can see the superficial epidermis here, and then do you see the basal layer here? This basal layer is still intact. You got one layer of cells here. Here they are. One layer of cells here, one layer, just one guy. This is your tombstones. This is your tombstoning. It's one single layer. It's layers of cells. And then look at all these other guys falling apart. They're literally falling apart. They're not attaching. So this is acantholysis of the epidermis, and you'll see a tombstone pattern of these remaining basilar cells because hemidesmosome's okay. Now, oral involvement. I always remember vulgar, bad words coming out of your mouth. Look at this blister in his mouth. Look at this blister. Blister. There you go. Blisters in the mouth. Not cool. Don't want blisters on the mouth. That's definitely going to get infected. And then finally, the way you're going to diagnose all of these is doing a skin biopsy. We'll see where the blister is. But more importantly, we're going to do immunofluorescence. When we fluoresce it, I think you can see the blister here. Here's the low epidermal blister. But do you see the IgGs around each keratinocyte? So it literally creates like a net. I mean, it really looks like they're surrounded. It looks like net. So they call this a fishnet pattern. IgG in a net. IgG in a net. Okay? What kind of cancer risk? Well, all autoimmune diseases have a higher risk of lymphoma, right? All autoimmune diseases have a higher risk of lymphoma. Unfortunately, pemphigus vulgaris, they usually die of it. They don't live long enough to develop any cancers because this is one that pemphigus superficial ruptures easily, get infected and die. But if they did survive, autoimmune diseases are usually associated with a higher risk of lymphomas. Lymphomas. Okay? So that's pemphigus. And the way I remember it is Nikolsky. Nikolsky, the Russian hitman. The only thing that will save you is Natasha. Natasha with her fishnets. That will distract me. Otherwise, tombstones for you. Vulgar words are coming out of my mouth. Pemphigus, it's a killer. It's a killer. It's a Russian hitman. And I wrote a song about it called Nikolsky. Maybe I'll send it to you. All right, now let's compare it to bullous pemphigoid. This is older people. Oi, I'm old. Oi, I get these blisters, but they're deep. The skin is intact. They don't rupture. So I'm going to come with all these blisters, usually my inner thighs, my forearms, but they don't rupture. So this one lives. You start steroids, and they do great. They do great. So this one's fairly common. It's in older people, and you give them steroids, and they do great. You give them steroids for a while, it goes away. When it comes up again, you give them steroids. Now, where are the antibodies going to be located? Well, they're going to be at the hemidesmosome. So they're going to be at the dermal-epidermal junction. So you're going to see IgGs at the junction with the hemidesmosomes. So it's going to be like a line at the dermal-epidermal junction. So they call this a linear, not a net. The net was here. A linear deposit of IgG at the dermal epidermal junction. That's where it's going to be located. So again, you got to be able to tell these apart based on their pattern. So this is a line. So let's take a look at it. Okay, oh, I forgot. I'll come back to this one in a second. Let me go here. Bullous pemphigoid. Now notice, this patient comes in and says, Doc, look, I still have blisters. A couple of them popped. This one popped because I was playing with it. This one popped, but this one's intact. This one's intact. This one's intact. This one's intact. See, you're going to see intact blisters here because they're not going to rupture as easily. Obviously, if you sit on that area, it'll pop. If you push on it real hard, it will pop. But they don't rupture very easily. They're very tense, but they don't rupture very easily. Here it is. Now, I think you can tell the entire epidermis is here. The entire epidermis is up here. And this is just dermis. This is just all dermis. So the epidermis separated from the dermis, and you got this deep vesicle that's not going to pop very easily. Now, what does it look like when I put immunoglobulins in there? You're going to see a linear pattern. See the way it's lighting up here? A linear pattern at the dermal epidermal junction. Here's the epidermis. Here's the dermis. This is where the hemidesmosome is, right here. See that? So I want to try like this. Oi, I'm old. Pemphigoid, I'm old. Oi, I got blisters. Oi, I don't like them. But I live, so I go to the mall for my life. Honey, because of you, I walk the line. Because of you, I walk the line. An old guy following his wife in the mall. See, you guys, you're too young. You don't understand who runs the world yet. Gentlemen, you have not been trained. Women run the world. You will be trained. They will train you. Don't worry. You're young. You're still finding it. Gentlemen, you go to the mall with your girlfriend or wife. How many shoes does she want to look at, guys? How many shoes does she need to look at? You're like, oh man, come on, let's go. The game is on. Just pick one. That one's fine. Pick those. Those are great. And she's like, but what about with the purse? Let me try with it. And you're like, no, just pick one. Ladies, how many shoes do you have to look at? All of them, twice, with different outfits, right? I know. So you have to train your man to, yes, honey, yes, stay there, yes, honey, I'll give you my opinion, right? Meanwhile, the guy just wants to run. So I'll be honest with you, ladies, we don't care about your shoes. We don't care about your purse. In fact, we won't notice unless you're naked. Then we'll notice. Or if like you show up in a hot car, I will notice the car. We don't notice. It's not important to us. You'll never go to a party and the guys are like, oh my gosh, you see what she's wearing? That doesn't match that. We won't even notice. Ladies, the reason you dress is for yourself so you feel good, but really you're dressing for other women. Because when you go to the party, you don't want them to say, oh my God, right? That's the reason you dress. You dress for yourself to feel good and for other women. Trust me, if you don't brush your hair, we love it. If you walk out with uncombed hair, we're like, oh man, look, she's so wild, love it. But all the women are gonna rag on you. So that's why you're dressing. So ladies, if you ever wanna get your man, you wanna get him real good, walk up to your man and say, honey, notice anything different? And we will be like, we don't notice. Bring home a new Nintendo, we will say, I notice. Wow, that's the new one. Does it have the new Zelda game? We will be all over it. We'll know how many bits it's got. We'll know all the capacity. Shoes, as long as they look okay, I'm cool with it. I know, right? Crazy. So you can get your man by just asking, do you notice anything new? Now, gentlemen, since you now know this, you must fight back. You must fight back. If she says, I'm going out shoe shopping, you write down shoe shopping, because you're never going to remember. Write down shoe shopping. Now she comes back in. Oh, honey, you're back? Nice shoes. Wow. I would never have noticed. Glad I wrote it down. Oh, you're going to get your hair cut? Haircut. Right. When she goes back, oh, wow, I like what you did with your hair. One time my girlfriend changed her hair color. She was like, do you notice anything new? I didn't even notice. I guess I have too many Y chromosomes, I guess. Crohn's disease. I guess I should have noticed that. How embarrassing. But yeah, this is very important. So, gentlemen, you will be trained. You will be trained. Your woman will bring you to the mall, and at that point, you don't fight it anymore. You say, yes, honey. You walk by it. Because of you, I walk the line. Oi, I'm old. Oi, woman, linear, like a line. Because of you, I walk the line, right? And isn't it true that I think she died and then he died right after her, Johnny Cash? It's like he couldn't live without her, or she couldn't live without him. They died within like 2 weeks of each other, I think. Because of you, I walk the line. Very cool. All right, so I try to make these silly for a reason. These are difficult to remember, the differences between the two. But hopefully with these crazy stories, you'll remember the difference between the two. Between pemphigus, boo, hiss, and pemphigoid, oi, oh, oi, I don't die. All right, and again, the real key distinguishing feature is not just where the blister is, that's very helpful, but the immunofluorescence, and it's easy for them to test it. One's a net, one's a line. They're both IgG. Now, I just want to go back here and tell you, 80% of pemphigus is vulgaris. That's the most common type. But there's other types, and I just want to mention this one, follicularis. This is going to be a little bit more superficial, so it's not as bad. So let's come back here. Just want to put this one here. Pemphigus vulgaris is most common, but pemphigus foliaceus, ooh, that sounds so bad. But anyway, this is the one that's more benign. It's a more benign form. Why is it more benign? Because it's more superficial. Now, take a look. It's common in Brazil, not so common in the U.S., and we have antibodies against desmoglein 1. Remember, desmoglein 3 was the one that was deep. Desmoglein 1, if we go back here, desmoglein 1 is located more superficially. So if you get blister up here, well, if it pops, I still have all of this intact to protect me from infection. So that's why this is going to be it's going to be very superficial and therefore less likely to get infected. Not like the deep one. When the blisters and ruptures here, you only have one cell layer to protect you against bacteria. You just have the tombstones, right? So that's why this one's going to get infected and this one is not going to get infected. Just make sure I didn't miss anything here. Different antibody, so therefore you get superficial. It's the granulosum layer. So this granular layer here, up here, that's where it separates. So notice, all this is below it, still intact, to protect you against infection. So again, you get these little blisters that'll ruptures over here, but not gonna die from it, it's so superficial. Cool. All right, pretty low yield too. Remember vulgaris. Now, last one no one confuses. Dermatitis herpetiformis. Now, first of all, they call it herpetiformis because it looks like herpes. Grouped vesicles. Grouped vesicles. So it looks like herpes, but it's itchy. Herpes is itchy. Herpes is painful. It's painful. So very big difference here. I'm just going to put it here. Itchy, grouped vesicles. That's why they call it herpetiformis. It is like herpes because it's grouped vesicles, but it's not painful, it's itchy. Now they usually occur on the extensor surfaces, so very common by the elbows, right here by the elbows, and of course the buttocks. It's the extensor area of the buttocks. So blisters, grouped vesicles like herpes on your butt, it can be confused with herpes there, right? That area. All right, so that's what you usually see at elbows, sometimes knees, buttocks. These are common areas. Now, the blister is usually subepidermal, so it's very similar to this one. So you're not going to die of this. You're not going to die of this. They're deep, very deep, so they're not going to rupture easily. So again, you're not going to die of this one. Now, who gets it? Well, it's autoimmune, so it's autoimmune area. It tends to be males more than females. Usually you think females, but it's males more than females. But I want you to remember the association with IgA diseases like celiac sprue. This is usually associated with celiac sprue on a USMLE exam. It can happen by itself, but it usually associated with celiac sprue because celiac sprue makes IgA against gluten. Do you remember the component gluten, gliadin? So here's what you'll see. You'll see IgA antibodies against gluten, which is gliadin antibodies. You can also see IgA against the endomysium. And do you remember the enzyme transglutaminase? Celiac sprue had those antibodies too? Yeah, well, IgA is secretory. So in celiac sprue, you're supposed to secrete them into the bowel. Well, in rare patients, some of it IgA will back up in their blood, circulate around, and deposit in the skin. and cause blisters. So this is IJ against the gluten and the translactaminase and endomysium that basically cross-react with reticulin fibers in your own skin. So it just gets stuck in your skin instead of getting secreted. And this is going to create microabscesses, and it's basically going to cause the dermal epidermal junction to separate. And that's why you get these deep vesicles. Deep vesicles. Now let me just draw it. Here's my epidermis. Here's the epidermis. Down here is the dermis. Now what happens is IJ deposits at the tips of the dermal papillae. So IJ deposits there, IJ deposits there, IJ deposits there. It deposits at the tips of the dermal papillae. Now when it deposits there, it causes inflammation. So you're going to get a little separation because it's right close to the hemidesmosome area. You're going to get a separation of the epidermis and dermis. So you're going to get a little blister there, and then you're going to get a little blister vesicle there. You get another one here. So notice, grouped. They're next to each other. Grouped vesicles that are kind of itchy. Because inflammation. So very important. This is inflammation causing separation of the epidermis to dermis. Now, if I did immunofluorescence, first of all, you're going to find IgA, and it's going to look like granules. Granules at the dermal papillae. So we had IgG in a net, we had IgG in a line, and now we have IgA as granules. So you better be able to tell these apart based on immunofluorescence, because they're all autoimmune. They all have antibodies, different antibodies though, against different things. And then you got to know that definitely the immunofluorescence, what they look like, where the pattern looks like. So IgA is granules. Now let's take a look. Here it is, elbows, very common site, elbows, buttocks. And you'll see these itchy, look, they're grouped. Here's one, here's another one, here's another one. They're kind of grouped. Grouped vesicular lesions that are itchy on the extensor aspects. Buttocks too, you'll see them on buttocks too. Now what you're going to see is right here at the tip of the papillae, you're seeing a bunch of neutrophils here. There's a little microabscess you're developing here because of the deposition of IgA and complement. In comes neutrophils, and notice the way they cause the separation. See the white space? The epidermis has separated from the dermis at this area. So there's your little vesicle, this white space. That's the vesicle. So epidermis is intact. It just separated from the dermis because of the inflammation. All right, you'll see neutrophils, you'll see the subepidermal blister, and in immunofluorescence, you'll see IgA deposits at the tips of the dermal papillae. Cool. Now again, how are you going to treat this bad boy? Well, you tell me, how do you treat celiac sprue? How do you treat celiac sprue? Right, if you stop the IgA from being made in the first place, it'll go away. So we're going to treat it with a gluten-free diet. Gluten-free diet. That's how we treat celiac disease. If you stop what you're allergic to, you'll stop making IgAs. If you stop making IgAs, they'll stop backing up into your blood and getting stuck in your skin. So gluten-free diet is your number one treatment. Now, what if the board says, despite a gluten-free diet, the vesicular lesions continue? Okay, if the gluten-free diet does not work, then you can add a drug called Dapsone. Dapsone. That's like your second line. So gluten-free diet is usually the treatment of choice here. It'll help the celiac and it'll help the dermatitis impetiformis. If it fails, well then for dermatitis impetiformis you can add Dapsone. How it works is unknown, but Dapsone seems to work pretty darn well if the gluten-free diet doesn't work. Okay, so Dapsone, second line, sulfa drug. All right, I think we got that covered. Now, here's an inflammatory disease that is near and dear to our hearts. Well, no, not near and dear to our hearts. This gave us a lot of heartache as teenagers. Maybe not you, but oh my gosh, did I ever suffer from this? So, acne vulgaris. Yeah, nasty looking blackheads and whiteheads. Ugh. Now, it's a self-limited inflammatory disorder of the sebaceous follicles. So too much sebum and follicle plugging. You plug up the follicles, the sebum can't get out, bacteria are going to proliferate, you get inflammation, pus. So you get these papular and pustular lesions And of course, if they rupture, if you try to pop them and they pop into the skin, and you don't get the pus out, you're going to wind up with scarring. Not cool. You get all this scarring, and as a teenager, it's the last thing you want. You're so awkward, you're trying to fit in with everybody else, and then your face looks like a pizza. It's like, man, could you curse me anymore? Right? My body's changed. I know, crazy. All right, so this is a disease of teenagers, mid to late teens, all about the hormones, right? Males equal to females, but males have much more severe disease. Androgens, baby, androgens. Now, associations, drugs. So steroids, people taking steroids break out. Hormones, testosterone is the biggie. That's why it's much more in males. But bodybuilders too. Bodybuilders, they break out with acne too. You got gonadotropins, contraceptives can give you a breakout of acne. Drugs, bromides, and so forth. All right, now let's come here and talk about contact. Well, if I have a lot of oil, it'll plug up these little follicles and increase my risk. So oils getting on your skin, hydrocarbons on your skin, that can also lead to tumors too, squamous cells, coal tars, anything that kind of clogs up the pores. And of course, anything that occludes, so heavy clothing that doesn't let you breathe, skin, cosmetics trying to cover everything up, well, that'll cause more plugging. And tropical climates, we're sweating, more stuff on the skin to clog up the little pores. Now, there's two types. We have non-inflammatory lesions, and we have inflammatory lesions. Now, for non-inflammatory types of lesions, we have comedones, open comedones and closed comedones. Open comedones are small follicular papules with this black melanin keratin plug. So you got this black, it's called a blackhead. So these black melanin pigmented keratin is plugging up the follicle. Now, what about a closed comedone? Well, that's where I don't see the opening. It's basically pus under the superficial layer of the skin. So the follicle's is basically plugged up. You got a papule with a central plug. So this is more like a white head. So a white head, see a white plug. So blackheads and whiteheads. Now, inflammatory is important because when you get inflammation, you can get scarring. So these things get inflamed. So we got blackheads, whiteheads, and now we're going to get red papules, nodules, and pustules. And this is what can lead to scarring. Now, what's the mechanism of acne? Well, there's a bunch of things happening here. Number one, we got a keratin plug blocking up the outflow. So when you plug up these pores, now you're going to get sebum that's accumulating, and bacteria are going to have a field day growing in that. Now, number two, because of androgens of puberty, other androgens, you're going to get hypertrophy of the sebaceous gland. So that's one of the reasons males tend to get more severe disease than females, because of the sudden surge in testosterone and other androgens they get at puberty. So the androgens cause a lot of sebaceous glands. So I got a plug blocking everything, and now I'm making more of the sebaceous stuff. Now, once you get plugged up, and this stuff accumulates, now bacteria can start growing in it. So we got lipase synthesizing bacteria, which is Propionibacteria acnes, perfect name for it. And this is going to wind up colonizing this hair follicle. It's going to take these lipids from the sebum and convert it to inflammatory fatty acids. This is what's going to lead to the inflammation, the erythema around these things. We have a blackhead, it's not red yet. Then it gets red and gets inflamed, becomes a pustule. I get scarring. All right, now inflammation of follicles also associated with the release of cytotoxic and chemotactic chemicals, so neutrophils are now going to come in. Now, how can we try to treat this bad boy? Well, we can use antibiotics for the bacteria. That's certainly one thing we could do. But certainly a favorite is right here for boards, giving synthetic vitamin A derivatives like isotretinoin. Which is basically a form of vitamin A that's going to mature. It's going to mature this stuff. So you get less plugging up of the follicles, you get less sebum production. So it's very good to try to slow this down. Retin-A is what they call it, Retin-A. So make sure though, if you're going to give it a woman, Retin-A. If you give a man, it's okay. But for a woman, Make sure she ain't pregnant, because this could be teratogenic. So make sure no pregnancy when you're going to take Retin-A. All right, acne, finally, get rid of it. I don't want to see that thing again. Yuck. Only a couple lesions to go here. How about this one? Panniculitis, inflammation of the subcutaneous tissues, the adipose tissues that underlie your skin. So inflammation of the subcutaneous adipose tissues. Wow, that's an infection deep in your skin, huh? Now, it's most common on the lower legs, like on the shin areas. That's usually where it occurs most commonly. It could be subacute, so it comes on relatively quickly, but not that quick. Or it could be more chronic. Now, subtypes. There's only 2 types I want you to know. There's actually a lot of types of panniculitis, but for board purposes, 2 types you need to know. Erythema nodosum, red nodules, and erythema induratum, red and thick. Red and thick. All right, now, erythema nodosum. What do I need to know about it? Well, this is very common. You're going to see it associated with a lot of diseases. But here's the rule. I want you to think of this with granulomatous diseases. Think of it with granulomatous diseases, like fungal infections. Do you remember coccidioidomycosis? We had desert bumps for coccidioidomycosis. These are the desert bumps. TB, that's granulomatous. Leprosy, sarcoid, inflammatory bowel like Crohn's disease. These are all granulomatous diseases. When they get granulomas in the soft tissues of your skin, you get erythema nodosum. And again, they're usually on the shin area, so red, tender nodules on the shins, lower extremities most common. It's associated with many of the infectious agents, like strep can do it, TB is a big one, leprosy is a big one. And then the inflammatory diseases like sarcoid, inflammatory bowel disease, these are biggies. And every once in a while I'll see it with a paraneoplastic malignancy as well. But I want you to think granulomatous diseases, Crohn's, sarcoid, coccidioidomycosis fungus, leprosy, TB. That's, if I'm only going to learn one thing on this slide, that's what to learn. Erythema nodosum is red bumps on the shin associated with granulomatous diseases. Done. Now we also have another form called erythema induratum, which is a thick red area, and it usually occurs without an underlying disease. So it just occurs, we're not sure why. It's probably a vasculitis of the deep vessels. That's probably what's going on. So we see this with lupus from time to time. I'll get this lupus panniculitis. Lupus panniculitis. So it's basically the blood vessels are getting inflamed, so the tissue in the deep subcutis gets inflamed, gets swollen, gets red thick and thick, induratum, erythema induratum. Okay, so again, kind of low yield, just think about it with vasculitis. All right, last category is skin infections. So I'm just going to power through this. We get these 3 done and we're done. We don't have any more, we don't need to do anything else. I'm just going to continue and finish these 3. 3 skin infections, which you did in microbiology, but it's always nice to hear them again. We got verrucae, which is a $10 word for warts. We got muscum contagiosum, molluscum contagiosum, and we got impetigo, cool diseases. So first one is warts. We know everything about warts. You can get them genitally, you can get them on your hands, you can get them in the cervix, lots of different things, but we know it's caused by human papillomavirus, HPV. Now, the way you get transmitted is by direct contact. So depending on where it is, it can be sexual contact or just any kind of physical contact, but you also get it from auto-inoculation. Whoa, that means if I got them here, I can put them somewhere else? Yeah, depending on what you're touching, you could put them in other areas. Yikes. Yeah, so auto-inoculation, you can give them to yourself in different areas. Now, these are usually self-limited. So it's self-limited. The immune system often will come in and finally take care of it. So when you get a wart, they often regress over months or years. Not every case. Some will keep going and get bigger and bigger, but a lot of them will actually come and then they'll go. Now we've got lots of different subtypes here. We got Verruca vulgaris. This is the common wart. It's the most common type. This is where they say, oh, don't pick up a frog, you're going to get warts on your hands. It ain't from the frog. It is from the HPV. Now, it's most common on the dorsum of the hands and sometimes on the face as well, especially like the eyelids. And it's usually due to HPV 2 and 4. 2 and 4 for common warts. Now, what if it occurs not on the dorsum, but on the palm? The palm. Well, then you call it verruca palmaris. It's on the palm. What if it's on the bottom of your foot? Oh, then we call it plantaris, which is plantar warts. Warts on the bottom of your feet. Now, these are important because they're fairly common. People are going to come in, they went on a vacation, they were staying at a resort, and they're running around without their shoes on. Well, when you're in public places with no shoes on, you can step on somebody else's wart that they stepped on and left on the floor, and you got it now too. Also at college, a lot of the college kids are going to use the same showers. Well, now you get a chance of transmitting it, right? So get it from the shower. Now these are benign, but they're often painful, and they're very hyperkeratotic. They get very thick. So thick, sometimes painful, not cool. They're usually associated with HPV 1. Okay, so these are kind of the low risk HPV, low risk of turning to cancer. Now we also have a type called verruca plana. It's just a flat wart. It's a wart that's kind of not raised, it's kind of flat. It's like a papule that's flat, like a plateau kind of. So small, flat papules, usually on the face, and this is usually type 3 and 10. Again, I don't think I know all the subtypes. I remember 1 through 4 you get from the floor and from hands and floor, 1 through 4, that's what I would know. Then I would know 6 and 11 because that's genital warts. That's important to know. And these often make large, like cauliflower lesions. Yikes, I don't want to see that on a vulva. Yikes, that's like cauliflower. So these are called acuminata when they get large. So these papillary squamous proliferations anywhere in the anal genital region of males or females, and they're due to 6 and 11. I was over 6 and 11 go to heaven because this is benign. It won't kill you, it'll just kill your sex life. That's it. Never want that. Condyloma acuminata. And by the way, it's one of the most common sexually transmitted diseases. One of the most common. Wow. All right, now what about Bohinoid papillosis? What the heck is that? Well, these are multiple papules on the genitalia that often regress, but they can also transform to squamous cell. Okay, if it's going to turn to squamous cell, which HPV should we be thinking of? 16 and 18. So Bohinoid papillosis are these white papules that you'll see on the genitals that often regress, but they can progress because this is a high-risk type. And of course, squamous cell in situ, by the way, this should be over like this. Squamous cell carcinoma in situ, well, that's cancer. So definitely 16, 18, 31, 33, because of the viral oncogenes E6 and E7. E6 and E7. E6 knocks out the guardian, P53. E7 knocks out RB, which is a governor of the cell cycle. The governor from the Walking Dead, the governor. All right, under the microscope, what are we going to see for pretty much all these warts? Well, we're going to see verrucas. That's where the skin is, the epidermis is thrown up into these large kind of papillary structures. So verrucas or papillomatosis hyperplasia of the skin, and we'll often see koilocytosis, which is a vacuole around the nucleus. The nucleus is often dark and crinkled. So we call this a fancy term, a clear space around the nucleus. This is an HPV viral effect. We call it koilocytosis. Whenever you hear that term, HPV is nearby. So remember that term. Bowen's disease, yeah, but this is similar. Bowen's disease was squamous cell in situ. So Bowen's disease is one of the names we use for squamous cell in situ. So similar. So Bowen's is squamous cell in situ. What is Bowenoid? Well, it's like it, so it may progress, but it may regress too. So it's very similar. It's a dysplasia of your skin, but it's not full-blown squamous. If it's full-blown squamous cell in situ, we call it Bowen's disease. If it's just more dysplastic, it still can regress and go away. We call it Bowenoid papulosis. That's the only difference. So Bowen's and Bowenoid, like Bowens, but can still regress. Remember, squamous cell carcinoma is not going away. Once you have squamous cell in situ, it's going to stay there until finally it becomes invasive. You must do something about that. Dysplasia, all this is dysplasia, right? These are cells that are going a little weird. They're proliferating, but it's all low-grade dysplasia, and it goes away when your immune system kicks in. Yeah, we often see it grow a lot during pregnancy. Then when the pregnancy goes away, the immune system comes back for the woman, boom, they go away. So they'll go away when your immune system springs back. All right, very good question. And here's what they look like. Here's the common wart. They said, oh, you must have kissed too many frogs here because you got these. Now look, if this is all over your hands like this, you think they can transmit it to their lips? Think they can transmit it to their face, their eyes? Think they can transmit it to other parts of their body? Yep. Now take a look at this epidermis. Very thick, very thick. Notice the way it's thrown up into these little papillary type features here. This is called a verrucous appearance. Verrucous, just being thrown up. Look at the hyperkeratosis. Very thick granular layer. And then here we have an HPV in situ hybridization, a fish. We're looking fluorescent in situ hybridization, and we're looking for the HPV, and sure enough, there it is. And do you see the clear space around this one? It's got a clear space around the nucleus. That would have been a coilocyte on, if you did H&E. You would have seen a coilocyte there. See the little clear space around the nucleus? That was a coilocyte. And all this dark stuff is the HPV within these squamous cells. Okay? All right, so again, very thick skin, a lot of thick granular layer here, a lot of keratin, a lot of hyperkeratosis here. That's what you're gonna see with common warts. And actually most warts look like this. All right, now second infectious disease that they like to talk about, especially this one in wrestlers, college kids who are wrestling, is molluscum contagiosum. Now with a name like contagiosum, it's contagious. So that's why they like wrestlers, because they're gonna be on skin to skin, right? Somebody wrestling, somebody doing martial arts, somebody who's in contact with another person, and sure enough, they can transmit this. Okay, so touching another person, so close contacts type stuff. Now it's all because of a virus. It's DNA pox virus. Now this is a self-limited skin disease, so it will go away on its own. Viruses come on their own. The immune system eventually clears them, and it's spread by direct contact. So high school wrestlers, martial arts. What else could the board think of that would put young people touching each other? I don't know, I can think of some things. But martial arts, wrestling, it's young people touching each other. Now, it's common in children and young adults, and the description is classic. When you look at it, it looks like a papule, so it's raised, like a papule, but it's umbilicated. In the middle, there's a little, hole in the middle, and coming out of it is cheese. You got this cheesy, if you squeeze it, it's like a zit. This cheesy stuff comes out, and that cheesy stuff is full of the virus. Yeah, so you see these cup-shaped papules. They're like a cup with a central little cavity there that expresses this stuff. And this stuff has a lot of what's called molluscum bodies. These eosinophilic cytoplasmic inclusions, here they are. See these pink inclusions of viral protein. So these cells are basically just full of viral protein, molluscum bodies. Okay, so here is the skin, the epidermis, and then it's releasing, these cells are dying and getting released, and inside them you see all this pink molluscum bodies. These are all the virus. So if you squeeze these lesions and this stuff comes out, touches you now you're gonna get this DNA virus in your skin, and you could develop some of these umbilicated papules as well. All right, last one is impetigo. It's a superficial bacterial infection of your skin, and it's very contagious. So these could be transmitted from one kid to another kid at school. Now, the most common organism is going to be Staph aureus. That's the main type. But I want you to notice group A strep can do it too. Now, why do I want you to know that? Because if it's due group A strep, this can trigger glomerulonephritis. This can give you a post-streptococcal glomerulonephritis. That's pretty important because we always think about strep throat. We always think strep throat. Well, they like to use impetigo on the exam. They like to give you impetigo because impetigo, everyone should think staph first. Always think staph first. But group A strep can do it too. So that's very important to remember that. Okay? So think always Staph aureus is when you see this golden honey-colored crusting lesions on the lips, the face, the fingers. When you see this, you know it's impetigo. Think staph, but strep can do it too. And of course, there's contagiosa and there's impetigo bullosa. It's just the size of the papule. So if they're small, contagiosa. If they get really big, then you call it bullosa. Now, what does it look like? They describe it as honey-colored, golden, crusting, honey crusting. This is the classic description. Sounds like a breakfast cereal. Honey crust cereal. Don't eat this, it looks nasty. Now, why is it so honey yellow? Why is it yellow? Because it's pus. This is the accumulation of neutrophils in the stratum corneum. So you're getting basically right below the corneal layer a subcorneal pustule. Now tell me, this is kind of superficial, isn't it? Superficial, the corneal layer is at the very top. So it's right under the cornea, corneal layer, so it's very superficial. So you're not going to get septic from this. You're not going to get sepsis. This is very superficial. This is in the corneal layer. All right, now what is it doing? Well, the bacterial toxin is cleaving desmoglein-1. That's why your skin is kind of blistering and falling off here, because desmoglein-1. Now, where was desmoglein-1? Was that deep? Oh, that was superficial, like pemphigus foliaceus, right? Foliaceus. That was superficial one, right? And again, they didn't die either. Same thing here. The kid ain't gonna die. He ain't gonna get sepsis. This is superficial infection. Superficial. Desmoglein-1, the skin will kind of fall apart in the superficial areas. Since the dermis is uninvolved, they will heal without scarring, because it looks pretty nasty, right? But it heals without scarring once the bacteria disappear. So give some antibiotics once this is treated, or it can often go away on its own. It usually heals without scarring and no sepsis or anything else. Yes, we did it. So I give you some time here. We got half an hour, so you get extra time so you can go and study for the exam. All right, guys, thank you for hanging out with me. All right, I wish you guys the best of luck on the exam. So good luck, guys. Woo-hoo! We're done early today. I usually go over, so this is a change of pace. All right, take care, guys. Keep up the hard work. All right, see ya.